Here we go. All right. Good afternoon, everyone. This is the September 22nd, 2020 hearing for the Health Committee. I am Councilmember Christopher Burnett, Chair of the committee. We are also joined today by Councilmember Clark of the 14th District and member of the committee, and Councilmember Cohen of the 1st District, member of the committee. I'm trying to look through the list. I don't see any other committee members on yet, but I'm sure they'll be joining us soon. We are also joined by a host of representatives from the Council President's Office, the Mayor's Office, and a number of city agencies. Thank you all for joining us this afternoon. Before we start, I'm asking all speakers and panelists to mute yourselves when you're not speaking so that we can hear all of the speakers very clearly. Make sure that you identify yourself before you speak, because we are taking minutes in the hearing, and this will be aired at some point on Charm TV and online, so we want to make sure everyone knows who you all are. Be sure to speak slowly and clearly, and after you are finished speaking, please mute yourself again, so that, again, we can make sure that everyone is heard who needs to be heard. We are meeting to discuss Council Resolution 20-0239R, informational hearing responding to mental health crises. And the purpose of this is inviting representatives from the Baltimore Police Department, Health Department, Fire Department, Office of Human Services, Behavioral Health Systems of Baltimore, Baltimore Crisis Response, Inc., the 911 Call Center, and advocates of mental health to investigate how behavior and mental health crises are handled here in Baltimore, identifying gaps, and developing the best path forward for addressing and de-escalating mental health crises. I would like to thank Councilmember Cohen for introducing this resolution. I think this is an incredibly important topic for us to be talking about, especially what's happening nationally with police reform efforts, but also just addressing what we know locally, and that there needs to be a more comprehensive response to addressing mental health in the city of Baltimore, and this is a step in that direction. So I do want to give you an opportunity to speak and give us opening remarks before we move forward.
Thank you so much, Mr. Chair. Thank you to colleagues, and thank you to all of our distinguished guests that have joined us here today. The first step to fixing a system is to acknowledge the ways in which it is broken. And if we are going to be completely honest, there is something deeply broken about how we handle mental health crises in Baltimore. I want to be completely clear that this hearing is not an indictment of any single individual or agency. Indeed, there is good and even heroic work happening in pockets throughout our city. But the synapses within the systems aren't connecting. People's basic needs are not being met. Even worse, we continue to criminalize and punish behavior that is rooted in mental illness, not malice. The way we treat people with substance use disorder matters. The way we treat people with trauma or schizophrenia matters. When someone is suffering in a humane, decent country, you don't throw them in a jail cell. And we bear collective culpability for the outcomes that we see. I will argue that police play far too great of a role in responding to mental health crises, that cops are not clinicians, and that there is massive mission creep. But let's be clear, they do that because we ask them to. Because we've decided that when you see something you don't like, whether it's a bank robbery or a person experiencing homelessness, sitting on a park bench, talking to themselves, there are just 3 magical numbers for you to press on your phone to fix it. 911. That's wrong. This nation went through a needed process of deinstitutionalization, closing down large and brutal mental hospitals that too often functioned as prisons for people with mental illness. But we never figured out what was supposed to come next. At the same time, We eviscerated our already fragile social safety net, dismantling public systems that were built to support vulnerable people. Well, now our chickens have come home to roost. We are living through a global pandemic that is ravaging not only physical health, but our mental health as well. Baltimore is the birthplace of so many racist public policies like redlining, which have colluded to harm Black and brown people's mental health. We suffer so many deaths from unnatural causes, be they murder, suicide, or overdoses. There is so much grief in Baltimore that at times we can't even fully process it. As a city and as a nation, we are grappling with the greatest racial reckoning in a generation. We hear the calls from young people to truly step up and confront injustice. Amidst all this, we have a profound opportunity to put our egos aside and fix it, to come together like never before. It will take all of us, every individual and agency. We are a scrappy, resilient city with amazing people who solve problems with compassion and creativity. I'm excited today to hear from people across sectors and to start by hearing from people with lived experience dealing with our mental health system. And I will conclude by saying today's hearing is a start to a much longer conversation about how we as a city can do better by the people we serve. Thank you, Mr. Chair.
Thank you, Councilmember Cohen. So at the request of Councilmember Cohen, we are going to open the hearing with testimony and then go to agencies at the end. We do ask that questions be held the conclusion of both panels unless there's something pressing from the committee. I also want to note for the record that Councilmember Henry is trying to join us, and I think he can hear this, but is having some technical difficulties. But he is trying to log on and join us on this. Okay, so going from the agenda, we are going to start with testimony from those with lived experience, and the first individual I have is Tev Simone. Are you here? All right. Good to see you again. Go for it.
Yes, Christopher, how you doing? My name is Tevis Simon. How's everyone doing?
Sorry about that.
You gave me a new name, but all right.
You can go right in. My apologies for messing your name up. I'm sorry.
No problem at all. Thank you, Councilman Cohen, for inviting me to speak today. This is a great opportunity. What I wanted to share with you guys as a mental health survivor, as an advocate, as a volunteer, as also a mental health educator, I experienced a break-in in 2011. And naturally, I was hysterical. I was emotional. I didn't know if I would live through it. And I called 911 and I explained to them as I could that there was someone in my home. Unfortunately, the person was able to get into my home as I was calling because I saw them, like I heard the noise on the balcony. So that's when I called 911. The police came, but by that point, because the person that came into my apartment, I literally was able to run out of my front door because they came in through my patio, through my balcony. And please forgive me, I get a little nervous and anxious when I share this story. The police came, and unfortunately, I was not myself, not physically, not emotionally or mentally. I ran out of the home, barely dressed. I knocked on every door in the building. Finally, one of my neighbors answered. This was a neighbor that I was very close with at the time, and the police officer came. I was uncontrollably emotional, and there was some mention to the officer that I suffer with depression and anxiety, and that officer basically said to me, do I think that I could have been imagining that? Do I think that because of my anxiety that I could have been worked up over a sound or a noise? There was no consoling, there was no assistance in the sense of calling someone else, or even I wasn't even asked if I wanted to go to the hospital or if I wanted to have someone to talk to. There was no resource, there was no referral. There was just me, petrified, paranoid, emotional, crying, and the police officer just basically looking at me, shaking, and questioning what I felt honestly was my intellect, my common sense, what I know I saw, what actually happened. And let me just say, there was a break-in and they did get the gentleman, but it happened and there was no support there. And I felt very alone, very afraid. And I definitely felt judged. And I felt like the incident was minimized because the officer was told that I have a mental health condition. So that's a little bit about my experience, my testimony. I'm open to any questions or anything like that.
Thank you for sharing. I know that is never easy to share your story or share these kind of stories in a public setting. So I do want to thank you for that. Are there any questions from the committee? Councilmember Cohen?
Just briefly, thank you, Mr. Chair. Just, Tavis, I want to just say thank you. Sorry for the experience that you had. It should not have, that should not have happened. And again, I want to just reiterate what the chairman said, which is really appreciate your vulnerability and willing to share your own story in order to help us make the systems better. And so thank you for consistently doing that.
Thank you. Thank you all.
All right. Next, and again, I apologize to anyone that I'm not saying your name correctly. I am not the best at this. Sorry about that. So next we have Ken Juritsu.
It's Jersey.
All right, I'm overdue.
Okay.
All right, thank you.
Hello, everyone. My name is Ken Jersey, pronoun he, him, his. And this is my wife, Mary Jersey. We're members of the LGBTQ community. We run Hearts and Ears. We're also parents of children with special needs, well, young adults now, of special needs that also deal with mental illness. In our home, there were six of us that all deal with the children deal with special needs, and we all deal with mental illness. And we have an elderly parent in the home who is physically disabled and has health issues. So on the evening of August the 31st, 2018, our middle son, Jason, had an episode. He's autistic and he deals with a mental illness that causes him to have violent episodes. We had a situation with him where he got violent and proceeded to turn over furniture and go into a violent rage and proceeded to go into his room. We tried to call for help. My wife called BCRI, which in turn told her that they would not be able to come out that night. They would possibly be able to come out to help us that following day. So they suggested that we call 911. 911 is not something that we would have done usually, because Jason is highly triggered when it comes to seeing police officers. So, but in this case, because things were so bad, we needed to. So we proceeded to call 911, and we asked for an officer from the BEST team, because we were knowledgeable about the BEST team, and we had an educational thing at our center. We found out about the BEST team. So we requested a BEST officer to come out. We were hoping that the situation would help, which in turn turned into, it turned wrong on so many levels. The officer came in to our home, asked us what the problem was. We explained about our son's disability and his mental health. In turn, we also identified ourselves as his parents. The officer asked if he was our biological son. I explained to him that I'm his biological mother, but identify as his father, which in turn turned into a whole misgendering match. So, dealing with that, I proceeded to ask for the help that I needed with our son. He came upstairs. We asked him to come upstairs to talk to our son, who was, barricaded in his room. He asked our son to come out of the room, to come downstairs to talk to him. Our son refused at first. Eventually, he did come downstairs after the officer asked him several times. The officer proceeded to tell him that he needed to turn over the furniture and that he needed to calm down, which was something you cannot tell our son when he's in a rage the way he is. What happens is, excuse me, because we're still trying to process a lot of stuff that has happened, even though it's happened in 2018. Our son then proceeded to speak to the officer and just told him, just shoot me. We were yelling, trying to tell Jason not to tell the officer, not to tell him to shoot him. But Jason's mind, you can't control him. And we were trying to explain to the officer that he needed to go to the hospital. Jason refused to listen to the officer and he ran back upstairs. So we in turn tried to talk to the officer and let him know the importance of Jason needed to go to the hospital, because what's going to happen is when the officer left, that Jason would come back downstairs eventually, and usually his point that the people he comes after when he does go in a rage is either myself or our other son, Brandon. And he has physically attacked both of us in the past, previous to that incident. The officer refused. Our youngest daughter, who is autistic, was extremely triggered. She ran outside. My wife is trying to console her. I'm trying to talk to the officer. The officer's still misgendering me. Eventually, the officer hears Jason come back downstairs. The officer gets on his radio. He calls the other officers out to the house. It was about 6 of them that showed up minutes later. But before the other officers showed up, my son proceeds to reach for me. The officer grabs my son, and then my officer and my son the officer and my son are wrestling on the floor and fighting in the living room. And you can hear the officer tell my son, "Stop reaching for my gun, stop reaching for my gun." The other officers then come in the house while my wife has our youngest daughter and has our other son in the basement, who are traumatized downstairs. My mother's upstairs, who is 73, and she's yelling and screaming. The officers are trying to pin Jason down, and he's fighting and wrestling with the officers. Eventually, they get him pinned. They have him handcuffed, and then they have him shackled by his ankles. Jason was 19, 18, almost 19. He hadn't turned 19 yet. He was 18 years old. And eventually they got him shackled, and they waited for the ambulance to show up. And Jason was eventually taken to the hospital. I believe it was the officer supervisor who came out, and I explained to the officer supervisor what was going on. I also explained to the officer supervisor about the level of disrespect that I received being a trans individual, of being a trans parent and not being respected in regards to my pronouns. Eventually it ended with my child being taken to the hospital, other officers coming in to get my name for a report, getting my wife's name for a report, and eventually the other officer finally coming back to apologize after all of this is over with, which could have been avoided. Since then, we've gotten resources for Jason, but it's come to the point now where we've had to Jason has had to move to an out of state. to to live with my sister, to have a different environment because he is so traumatized as to what goes on when he sees police officers. There was a group of police officers that came a week after he came out of the hospital. They didn't tell us that they were showing up. We were walking out the door and we saw the police car pull up, and all of a sudden the officers come across the street, and it was supposed to be a well-checked call. But because he had already been traumatized seeing the other officers that he dealt with a few days prior, that he was upset when he saw the officers that showed up that day. So
he's still terrified of police to this day.
So until he moved to Oklahoma, anytime that he had an episode, we've tried to find other ways of dealing with it to try not to let it escalate, because we refuse to call the police. We refuse to.
Thank you. Thank you for sharing that. That's heartbreaking to hear. Are there questions from the committee on this? Okay. Seeing none, again, thank you for sharing. As I said before, I know this is never easy and does require a lot and can take a lot out of you sharing it in this way, but it's helpful for all of us to hear, and all the folks on the call to hear this feedback. Thank you. So next I have Maura Taylor.
Yes, that's me.
All right.
Hello, my name is Mara. I have 3 daughters. Their ages range from 17 to 37. So I've been doing this parent thing quite a while. I've lived in Canton for 20 years. One of my first jobs more than 30 years ago was working with the chronic mentally ill. So I've been a long-time advocate for shattering the stigma and for mental health services, as well as addiction services, having spent 5 years on the Alcohol and Drug Advisory Council in Anne Arundel County. And I've spent the better part of my career in various positions in public education. I say this just to let you know that I'm an informed person. I began my advocacy long before mental health hit my family. My youngest daughter, who is 17, is a super kid. She's a leader. She's a straight A student. Many of you actually know her. She's awesome. But 2 years ago, she began suffering with major depression. It was exacerbated by the unexpected death of my father, and her depression and anxiety continued. And then she began we're lucky. We have good insurance. I could get her a therapist. I could get her a psychiatrist. We did all of those things. Then she suffered a traumatic event where she was assaulted in, I guess it was a year ago, in September of 2019. That landed her sitting on the edge of the bypass of 95, where 911 responded because she was so distraught. She was taken on an emergency petition to Hopkins, and for some unknown reason, they just released her after about 8 hours of time. So after that traumatic event, her depression and anxiety increased, and she turned to alcohol to alleviate that pain. Between May of 2019 and March of 2020, she was emergency petitioned to Johns Hopkins 5 times. Every single time she was released. At most, she was there 12 hours. And this was through 911 calls because the situation would escalate. The most recent emergency petition by the police, she had to be pulled from the roof of my house. I think most of the Southeast District was there that day. It's horrifying and it's disabling as a parent when your child is in this level of crisis. And like I said, she's a super high functioning kid throughout this. She was still doing school. She was still getting good grades. She was still doing other things that made her seem fairly functional, even though she was spiraling downward. The last 2 calls to 911 seeking emergency petitions happened in late May and June of this year. In those 2 calls, the officers who responded in the one instance, because she got to know the drill, so she would become very calm. Anyone who's worked with the mentally ill for any period of time knows that they do not always present as hallucinating or incoherent or out of control or threatening or any of those things. I've seen it time and time again where suddenly they get very calm when the police show up, when the authorities show up. And she would do that. And the police officer said to me, well, she looks fine to me. And I said, well, are you a mental health professional? What is your training and background to do this assessment? Please call the Baltimore Crisis team. I am telling you, based on 5 emergency petitions in a year, that this child needs help and she needs to go to the hospital. And he said, well, there's only 1 crisis unit in the city and they're not going to come because they're probably busy. I said, well, I would like you to make an effort. And he suggested I call B-Cars. And I said, well, B-Cars only helps adolescents with medical assistance. So they're not going to help me because I have insurance. And so he was making some calls. He talked to an officer who had previously responded. And he came back. He said, yeah, the crisis unit's busy. I don't even know if he called them. He said, but if you want, you can go downtown and file a petition yourself. Well, I can't leave her in crisis to go downtown to file an emergency petition. So we struggled through that night and did what we could and contacted psychiatrists and family counselors and our therapists and all the resources that we are so very fortunate to have access to. The next time there was a situation escalated, I called the officers, and again, the officer said, and I was upset because she had actually attacked me, and he said, you're the one that seems upset, not her. And I said, well, she's the one that needs help. You've been here before, you know me. And he said, well, you know what? You can go downtown and get an emergency petition. And that was that. And then at that point, I did just that. Not that night, but I did go downtown. I was told by the commissioner and the judge who responded to me when I sought the emergency petition that that was wrong. That based on the history, the background, the information from me, he said sometimes the police officers will say that to you, but they really should do the emergency petition. And so he granted the emergency petition. She was admitted to Hopkins again. And this time I was fairly relentless, and we had her transferred to Shepherd Pratt, where she spent 8 days. By way of background, Shepherd Pratt is crisis response. They don't deal with comorbidity or co-occurring disorders for adolescents. So they are not a long-term care facility, nor are they geared to be one. In fact, there are 0 in the state of Maryland. So we moved her to the Care and Treatment Center in Pennsylvania, where she spent 28 days because they do deal with mental health issues co-occurring with substance use disorder. And then ultimately, where she currently is in Connecticut at a long-term therapeutic care center that is costing us $16,000 a month. I am not a rich person by any stretch of the imagination. I am fortunate in that my husband and I have lifetime retirement accounts that we can empty out and a house we can refinance to get her the treatment that she needs. I bring this to your attention because one of the critical components in this mental illness, trauma, addiction crisis that we find ourselves in is a complete and utter lack of equity and access. If you don't, you have to have lots of money to find treatment. Treatment doesn't even exist for adolescent females with co-occurring disorders in the state of Maryland. That is a serious, serious issue to get help. This is a long story to demonstrate a couple of important things. First of all, police officers, and I'm not faulting them, they signed up to be police officers. They did not sign up to be social workers and mental health professionals. And quite honestly, that's not the qualifications they have as their job. They are not qualified to make mental health assessments, unless by chance some police officer happened to have that as a previous background. But for the grace of God, my daughter survived long enough to get long-term treatment. The fact is, the refusal to EP her on 2 occasions could have resulted in her ending her life or hurting someone else's. Second, the resource for crisis intervention services, particularly for adolescents, are woefully inadequate. We must fund more social workers, psychologists, and other trained professionals to respond to mental health crises. 3, the number of psychiatric beds, particularly for adolescents and adolescents with comorbidity, is virtually non-existent. And finally, again, there's zero equity. We have good insurance. Even with insurance, there's not affordable treatment. Those suffering from mental illness and the disease of addiction or substance use disorder are floundering, suffering, and dying because of the lack of affordable or any services, particularly our children. We cannot and should not rely on police officers to do mental health assessments. We need to take that off their plates and free up some funding for mental health professionals who are trained individuals, because mental health does not always present in typical ways. Our city is in crisis. Our children are in crisis. Hurt people hurt people. We absolutely must review how we approach this crisis through an equity lens. Again, we're fortunate. We have retirement counts to drain, but neither we nor anyone else should have to do that in order to get quality, long-term mental health substance use treatment. It's a massive barrier to all those who need help and have zero access. When you leave here today, my challenge to you is to find a psychiatrist for adolescents who takes insurance. And then find a psychiatrist for adolescents who takes medical assistance. I wish you a lot of luck. I challenge you to find affordable treatment for adolescents, long-term, over 28 days, inpatient, residential for co-occurring disorders. Again, good luck. We're not even at a place where we're putting a Band-Aid on a bullet wound at this point. We are simply bleeding out. And we are seeing that every day on our streets as hurt people hurt people. So I implore you to make this a top priority, because until we address the trauma and the lack of available services for those suffering from mental illness, we are not going to ebb the tide of violence and trauma and the results that we're seeing in our city. Thank you very much for your time.
Thank you. Thank you. That was powerful. Any questions from the council? Councilmember Cohen?
Yeah, I just want to first thank all the parents that gave testimony today. That takes a lot of courage, and we as a committee are in awe of you for sharing your story and using your voice to impact systems change. And Maura, I would say, knowing your daughter, she is a super girl and soon to be super woman, and you and all the parents that have given testimony are super parents. And you shouldn't have to work as hard as I know you have in order to get treatment for your children. So again, want to just thank everyone, and just say that I think you've really made this a very clear mandate for us. So thank you for your testimony.
Agreed. Thank you. Okay, we're going to now move to a panel of providers. First on the list is David Prater, Disability Rights Maryland.
Thank you, Mr. Chairman. My name is David Prater. I am a managing attorney at Disability Rights Maryland, and I also want to acknowledge and thank the previous panelists who testified and recognize their voice and the pain that they have experienced. Just for background about my office, who Disability Rights Maryland is, we are what is called the Protection Advocacy Agency for the state of Maryland. The protection advocacy system was started by Congress in the late 60s and early 70s to really monitor the conditions of facility-based care, such as state hospitals or other congregate settings for people with disabilities. Fortunately, we've moved away from that model, and we, as a society, have focused more on ensuring the civil rights of people with disabilities and their full integration into the community. However, what we have learned is that routinely there are a lack of community-based services for people with disabilities. And consequently, the criminal justice system has provided a one-way path back to institutionalization, whether that's in jails or state hospitals, where over 90% of all patients are called forensically involved or have some involvement with the criminal justice system. So this is a critical issue in terms of preventing and ensuring that vision of full community integration for people with disabilities and preventing reinstitutionalization. So it's a hard task, it's a big task, but the good news is we don't have to reinvent the wheel. I think experts do agree on what is needed to avoid this overcriminalization and institutionalization of people with disabilities. All the components, people agree on. 24/7 mobile crisis teams, crisis coordinating call centers, crisis respite programs. All of these are essential elements of a functioning and well-resourced crisis response system. In fact, in 2002, the Maryland General Assembly passed legislation recognizing that these are the services that need to be implemented in Maryland. However, funding for those services never materialized. And the result is local jurisdictions like Baltimore City are in a position of having to figure out how to create these systems without adequate funding from the state or other partners. And that is an extremely, extremely challenging task. I don't think that there will be any disagreement from other panelists on what those components are. I think everyone's going to agree that there needs to be more 24/7 mobile crisis teams. There need to be crisis respite programs. There need to be crisis call coordinating systems. I think everyone agrees with that. I don't think there's going to be disagreement there. I think what I can bring to the table and what our experience sort of shows or demonstrates to me is the importance of values that need to underlie these systems. It's not enough to have more crisis teams. It's not enough to have more crisis call centers or more crisis respite programs. We also need better crisis services. And what that looks like is, I think, connection to and accountable to the people that these services are intended to serve. Now, I think there are some principles that we really operate from that I think others would agree with. And so I just want to go through some of what those principles are. And these are principles that should underlie any system or service that we as a city decide to develop. One is that crisis response services should be culturally competent and should affirmatively address the racial trauma that Baltimore's historic over-reliance on law enforcement as first responder has exacerbated. No one should be turned away, and services must be available 24 hours a day, 7 days a week, 365 days a year. There is no wrong door. Anyone should be served anywhere and at any time. Peers should be included at all levels of crisis services. Crisis call centers, mobile crisis teams, leaders in operating crisis stabilization centers. And the pay needs to reflect the importance of the work. And it needs to be an accessible job for people with behavioral health disabilities and some of the barriers that would present. Crisis services and mobile crisis teams should resolve the overwhelming majority of crisis calls from the community without necessitating a higher, more restrictive level of care. Without the use of emergency petitions, without transportation to respite programs, mobile crisis teams, they're your frontline workers. They should be working to resolve the overwhelming majority of these calls in the community. To the point of some of the earlier panelists, crisis services for youth must be conceived and delivered on par with services for adults and should include consultation with teachers, family members, and other community members who may help facilitate linkage to effective community-based mental health services for adolescents. Crisis services should be safe for all participants. We should adopt trauma-informed practices and approach for our providers and implement no-force-first policies. People need to be voluntarily engaged in these services, not forced into them. Crisis services should provide adequate discharge planning to individuals with behavioral health disabilities to prevent cycling through crisis systems, emergency departments, jails, and/or prisons. And finally, the crisis system must be accountable to the communities it serves. The system should be regularly and objectively evaluated and must demonstrate transparently to stakeholders and consumers that the needs of its residents are being met. So these are just some principles about what needs to underlie these services. So again, it's not just more or not just increasing capacity. It's about having better services and more responsive services and services that are more connected to our communities. Thank you.
Thank you. Questions from the committee?
I have
Councilmember Clark.
I do, but I just lost sight of Mr. Prater. Wait a minute, let me get I'd like to look at him while we're talking.
He's still there.
I know, I went to, hi, Mr. Prater.
Hello.
Hi. There you are, okay. Okay, I do have a question, sir. I'm very interested in what you're talking about mobile crisis teams, 24/7, etc. And I know other people are coming along to talk, so I'm not saying give me the last word. But I've listened very carefully to what your principles or values are, and I think it gives me a good feeling about the thinking that's going into this. This is a very practical question, and here's what it is. You're talking about mobile crisis teams. I see that as people 24/7, diverse qualifications, in terms of responding to a crisis, a mental health, for example, crisis. So there's some kind of a team, but that's replicated around the clock. So my question, though, is listening to Ms. Taylor earlier, that's not good enough, or that's not enough. That's a crisis team. That's big enough in its own. But I feel you're dismissing some of the respite, other backup services that we lack, sort of dismissing them. I mean, do you see this crisis team as being actually a crisis team, which I think is right. But are you dismissing that we need also to add the backup kinds of services that Ms. Taylor talked about that don't even exist in the state of Maryland? Thanks.
Yes. Okay. So, and I apologize. There was some breaking up of the question.
Oh, I'm sorry.
That's okay. I think I understand it, which is, am I advocating for just mobile crisis teams?
Yeah, that's a good summary.
And the answer is no. What experts say, what SAMHSA says, is it operates as a system. It operates on the full spectrum of services.
Right.
I think my point about the mobile crisis teams is that if they're really skilled and have those skills, you can prevent a lot of the higher level interventions. I'm not saying that can happen in all cases, and that's why you have those higher levels of intervention, those crisis respite programs. And so those crisis respite programs can look like very different things. There is a model in New York called Rose House, which is sort of an emergency department diversion. And it's just a home that provides beds where people can come, get back to baseline. It's staffed by peers. Peers work with people who are at baseline to get them sort of a plan together to address what the issues are and work with them to get to where they want to be. So I think all of those services are really, really important. Our office, along with BHSB, hosted a symposium in November around these issues of crisis services. And one of the things that the community really identified as important for consumers and family members was permanent supportive housing, and how critical that was to preventing these crisis situations from happening in the first place. But it really is this full spectrum. I'm not saying, if you just have a mobile crisis team, you don't need all these other services. That's certainly. I'm sorry, you're muted.
Can you hear me? Okay. I totally agree with you. Right now, we've got the police doing those responses. If we had the kind of coordinated, diverse, mobile crisis teams of experts in these issues of mental health and crisis, that in itself would be fabulous. So I'm not short shrifting your presentation because I think it has to start there. Plus, it creates the informed demand in the city for the kinds of backups like the Rose House that you were just referencing. So that by having the first thing, we have the core of knowing what we need for the backups. So it can go in stages. But I was very impressed, although it's going Interceptor or something, the police radio. I read a lot of emails about what people learned from that, from the police radio, which I think is a valuable thing. What certainly was interesting to me to read about what they learned. How many calls go to the police that really belong to your team here? And I think the sooner we can do what we need to do and create that, but a good one, not just something else that doesn't quite have what it needs. I think it'll make such a difference in Baltimore. Thank you. Thank you.
Yes, I agree with that, Councilwoman. I'm happy to share with you some information from a team out in Oregon called Cahoots that does some very fabulous work. I'd be happy to follow up with your office on.
All right, well, if you'll go through, well, just go through the chairman here.
There you go. I will do that.
Councilman Burnett, because he's very good at getting us information. Thank you, sir. That way we'll all have it. Thank you.
Thank you. Are there any other questions from the committee? Thank you, Mr. Prater. Also want to note we are joined by Councilmember Isaac Slifer from the 5th District.
Thank you, Mr. Chair.
Okay, next on this panel, we have Cynthia Major Lewis, Dr. Cynthia Major Lewis, Director of Johns Hopkins Psychiatric Emergency Services.
Hi, good afternoon. My name is Cynthia Major Lewis, and I am an assistant professor here at Johns Hopkins, where I do serve as the director of the Adult Psychiatric Emergency Services. I do want to point out that I'm here today as a mental health professional, mental health advocate, and not representing Johns Hopkins. I do have my colleague here, Paul Nestat, who is going to probably start off because, we're here, we were asked to join this conversation. I'm so pleased to be part of it. I think for any change to take place, there has to be input from all the major stakeholders. And I will say that I came back 1 year ago, back to the hospital setting when I was given the opportunity to be embedded in our emergency department. I used to direct our emergency department from afar, where I was in our community clinic and would come supervise the residents. But I knew that for what I wanted to do, which is encompassing everything that's being discussed today, I knew that I needed to be in the emergency department. I'm looking at what's going on, what's broken, what's working, with the goal really of getting out into the community and working with the city, the state, even federal agencies to do this better. So again, thank you for welcoming me today. I wanted to pass this off to Paul. He's going to give an overview of what emergency petitions are, how they're generated in the community. Then I was going to provide an overview of what we do in the emergency department. Again, we could have discussions for hours over the things that work, the things that don't work, but we wanted to provide an overview of what an emergency petition is and how they're executed, how we handle them in the hospital setting, and then go from there. So, Paul?
Thanks, Dr. Lewis. So my name is Paul Nestat. I'm a psychiatrist at Hopkins as well, assistant professor and co-director of the anxiety clinic. And my inpatient work is with the patient population that really we're talking about. I work on the community inpatient unit with people that have comorbid substance abuse and serious mental illness. We were asked to come here today to give a little bit of background. So it's a little bit drier than some of the other really interesting testimony that you've had. I also, like Dr. Lewis, don't represent Johns Hopkins today. I'm here representing just myself as a practitioner, not to use my employer. So an emergency evaluation, which is also called an emergency petition or an EP, is used when someone's believed to have a mental illness that might be contributing to them being a danger to themselves or others. That might mean that they're acting bizarrely or aggressively. They might be trying to kill themselves or have started to kill themselves. They may be delusionally paranoid, lashing out. There's a variety of situations where these are used. As when I've been an outpatient psychiatrist filing an EP, some examples. I had the very first one I ever filed when I was a resident. I had a patient of mine, an outpatient who I knew very well, who had left me a voicemail saying, thank you so much for your help. Goodbye. I've swallowed a lot of medicines now, and I just wanted to say goodbye, and I didn't want you to blame yourself, right? So she didn't answer her phone, and so I filed an emergency petition, meaning the police would go to her house and bring her to the emergency room, which is what happened. And she fortunately survived. Another example, I had a patient's wife who called because the patient had gone off of his medications and had actually injured a neighbor dog and had locked himself in his room with a gun. So these are pretty common sorts of EPs. There are many different types, but those are some examples from my own practice. So a clinician can file an EP directly. There's a form online, you fill it out, get it to the police, basically describing what's going on. Or a layperson can file one, a family member, a friend, or even just a stranger can file one and hope that a judge approves it. They take it to court, a judge would evaluate whether it's reasonable, and if they grant it, then that's given over to the police, who then go to get the person. It's at that point, when the police go to get the person, that there's the most risk of sort of danger. Some of the stories you've heard today. There can be danger to the patient or the person subjected to the EP, the respondent, or to the police. I mean, if the person is armed. So it's a very tense situation. Now, because there's been major problems with EPs in the past, recently Ricky Walker, but going back for decades, there's a relatively new question, about 20-year-old question added to EP forms now, where the provider can write down if the person might have a firearm or other weapon, so that the police have some idea of what they're going into and can respond appropriately. But that's not always used. It's not a mandatory question to answer. So who's being EP'd in Baltimore? There was a resident at Hopkins recently, last year, who did a really interesting study, just to give you some background demographics of respondents to EP. So this is Marielle Cataldi. She's a doctor in Boston now, but last year a resident here. She looked at just a convenience sample of the last 9 months of emergency petitions that came to Johns Hopkins. So it's not necessarily representative of the whole city, but it was 9 months into 2018 of consecutive EPs. She found, since there's about 50 a month, she found about 506 emergency petition patients. 57% were male. 54% were between 18 and 35, so it skews young. 74% were African American, which is a higher proportion than the city of Baltimore, which is about 2/3 African American, although I'm at Hopkins catchment area, so I'm not sure the numbers there. Psychosis, meaning delusions or hallucinations, were present in 40% of EP respondents, and substances were present in the blood of 53%. It's just this idea of who's being EP'd to Hopkins. Once again, I don't have citywide data, and that's one of the things I'm going to suggest we could do something about. But anyway, so I'm going to hand this back over to Dr. Lewis, who's going to talk about what happens when they get to the emergency room, and she helps them. And then maybe we can come back to me and I can talk about what happens if they are admitted to the inpatient unit where I work. So Dr. Lewis.
Okay, thanks, Paul. So yes, in the emergency department, we are often the place where emergency petitions are brought. And unfortunately, patients are brought in handcuffs because they're being brought by the police. That's a whole nother discussion that is worthy. The police do have the ability to request medical transport if they're concerned that there's a medical complication that might arise during the transport. Patients brought to the emergency department on an emergency petition are being brought on a non-voluntary basis, okay, meaning that they're being brought against their will. Therefore, it's really incumbent upon us as the evaluating physicians to prioritize these patients and make sure that we can provide a proper disposition. Maryland statute dictates that emergency petition patients are evaluated within 6 hours of arrival to the emergency department, and we're charged with trying to find an appropriate disposition within 30 hours. Appropriate disposition being if they're been evaluated, determined not to be a danger to themselves or others, and can be discharged, versus have they been evaluated and now deemed to need admission, which we'll talk about a little bit later. There's a lot of factors that go into the point that this just doesn't really happen. I mean, we do try our best to see within 6 hours, but patients getting disposition within 30 hours, given COVID, there's been a lot of resources in the community that have been shut down. Beds have been decreased in facilities because of the social distancing. So our ability to see patients, dispo them, get them out to a psychiatric bed or something has really been impacted by this. So we're then charged with calling the state to make sure that they're aware that this person is in the emergency department against their will on an emergency petition and that they're still being held there. Again, we also have a duty as evaluating physicians to ensure that the emergency petition is valid. An emergency petition can only last for 5 days. So if a parent goes to the district court, is able to get an emergency petition by the judge, if they go to the home looking for the potential patient and they're not there, they have like 5 days to try to find this person. If someone comes on an emergency petition, which has happened, and we see that the date was maybe 10 days prior, then that petition is no longer valid, and we have to let the person go. And we do have some mechanisms that we're able to utilize if we're concerned that this person is a danger, but it's very important that we have to make sure that it's valid. Other things that we have to look for, we need to make sure that if an emergency petition was obtained by the court, we have to make sure that a judge has signed off on it. We also have to make sure that if the police bring the patient into the emergency department, we have to make sure that they're called the peace officer, but we have to make sure that they sign off on that as well. It's really important that we make sure these petitions are valid and executed properly, because if a patient does get admitted to the inpatient unit on an involuntary commitment, when they go before the judge to try to see if they can get let out because they don't think they need to be there, and then the treatment team is trying to argue why they are still a danger and need to be there, if the emergency petition was invalid, then that person can be let go on a technicality, which we want to avoid. Again, there are ways that the hospital has to try to mitigate that, but we want to make sure that things are done properly. I want to let you know what happens when a patient does come in. Usually, and it's important to keep in mind that a psychiatrist does not have to evaluate a patient who's been brought on an emergency petition. We're fortunate here in Baltimore to have University of Maryland, Johns Hopkins downtown, Bayview, other emergency rooms that do have psychiatrists on call. But there are other hospitals in rural areas or in the community that don't have psychiatrists. So any emergency room physician can evaluate a patient who's been brought in on an emergency petition. An evaluation usually consists of a medical workup. We like to draw labs on patients. We'd like to do a urine toxicology screen. They'll get a physical exam, a neurological exam. The goal is really to allow us to rule out any medical reasons that could be causing the behavior disturbance. Also, urine toxicology screening and serum alcohol level gathering allows us to see if there are substances like marijuana, especially synthetic marijuana, which we see a lot of, alcohol. These are substances that when ingested can really cause patients to look like they have a psychiatric disorder. When we do our evaluation, we are looking at family history, personal history, medical history, past psychiatric history, and looking at what is leading to the reason for the emergency petition in the first place, because we need to determine if there is now a major mental illness that is causing this behavior disturbance, which might lead to inpatient hospitalization. Some of the major mental illnesses we look at are psychotic illness like schizophrenia, schizoaffective disorder, also our mood disorders like major depression, bipolar disorder, our drug-induced, drugs can cause psychotic illness, they can cause mood disturbance. So again, our goal is to do a good formal evaluation so we can come, at a good determination to see if this person is going to be needing hospitalization or not. It is important to note that we do see a lot of emergency petitions generated by patients who are under the influence of drugs or alcohol, and often we try to give them time to either sober up or detoxify so that usually once they do, they can go back to their normal baseline and they can usually be discharged. Sometimes though, there's a lot of comorbid, especially here in Baltimore, comorbid illness between substance use and major mental illness. So usually we see about 24 to 36 hours. If someone's going to turn around, they usually do and can be discharged. But unfortunately, sometimes it can trigger, an exacerbation of their underlying illness, and those patients might still require hospitalization. I do want to talk about, just like when patients are brought into the emergency department on an involuntary basis, which helps to generate the emergency petition, once patients are evaluated, we then determine, do they need to come in on can they come into the hospital voluntarily? We will give the patients opportunities to sign a voluntary admission. so that they can come in, get help, be part of their treatment team. But if the patients have been evaluated and determined to need hospitalization and they don't want to come in, then 2 physicians in the emergency department are able to do what we call an involuntary certification, where we have to determine, one, that the illness is being driven by a mental disorder, and also that they're a danger to themselves or others. Fortunately, I think it was 2003, when I was a resident, we had to really answer the question of, are they in imminent danger? And that was a very high bar to try to reach. And I think hearing some of the testimonies from, the families, it really put the evaluator in a horrible position, because you would hear a lot of people say, well, what do I have to wait for my loved one or family member to go do something to themselves or do something to someone else before they can actually meet the criteria? So it was around 2003 where imminent got taken out per se, but there is still a high bar that we have to use when we're determining if we're going to be bringing someone in against their will. Maryland law requires physicians to carefully weigh a person's need for treatment against the unavoidable infringement on personal liberties, which is really what's happening when we're confining patients to an emergency department or bringing them into the hospital against their will. So again, our goal in the emergency department when someone's brought in on an emergency petition is to evaluate, quickly, efficiently, to make sure that we are getting enough information so we can really make a decision, which can be, life-threatening. Does this person need to come in against their will? Are they willing to come in voluntarily, or are they safe for discharge? And there's just some things to consider. Again, this is more of a generic. There's so many things that we can discuss, but the importance of us getting collateral information, and we call that getting information from family members or their loved ones, making sure that we can get a good understanding. Sometimes the emergency petitions might just say, patient acting bizarrely, patient seems stumbling, so if someone comes in and they're not really being forthcoming, we can look at that petition and say, well, this person wants to leave. And if there's really no one to gain information from, then it could result in us letting someone go if we're not observing anything ourselves, because it's the law. We cannot confine people against their will unless, they have been deemed to be a danger to themselves or others and being at the center with a mental disorder. So getting collateral information is key. Also, one of the problems that we've experienced is that, we end up getting a lot of the emergency petitions, where we're kind of doing a study now, I think the study that Paul referenced, to see how many emergency petitions are ending up in our location and how many have bypassed other hospitals. The law really does state that they are to be taken to the nearest emergency department. And when they're brought to places where a lot of people want to go to, then, it does create other problems. We've got a independent psychiatric unit within it's not even independent, but it's within our emergency department, but we have 2 secure holding areas, which used to be called seclusion rooms. We have 2 individual areas, but when, right now, I think we've got 8 emergency petitions right now. And when patients come in on emergency petition, they're often, acutely ill. They could be psychotic, they could be violent. So we have to really be careful that we're adhering, and this is where we're trying to work with the Baltimore City Police to make sure that their officers are really utilizing hospitals that are closest to them so that they cannot overburden, certain hospitals that are in the area. There's so many things. Again, COVID is impacting our acuity, the level of patients who are coming in on emergency petitions. It's important for us in the emergency department to educate families about our limitations due to the laws that have been created. And I think it's worthy of further discussion. I've had to have plenty of conversations with families, just to say, look, if it were up to me, your loved one is out there, and unfortunately, unfortunately, they are allowed to make, it's not even fortunate, but they're allowed to make bad decisions. I think a lot of families feel like, oh, look, my family member, they're not taking care of themselves. They won't come home, live at home. They've been homeless for years. They're, not taking baths. And, we have to reach that bar of some level of dangerousness to take someone's rights away from them. Now, it's different if it's like in a new onset illness, but someone who's been living homeless for 10 years, and that's what they want to do, and they're making their way, and that's how they want to live their life. We have to respect that due to not infringing on personal liberties. So again, there's so many conversations we could have about this, but I just wanted to kind of touch upon what our role is in the emergency department and what our duties are. So I will give it back to Paul about the inpatient setting.
I'm happy to say about the inpatient setting. I just want to add to something that Dr. Lewis said about patients that are brought from outside of the Johns Hopkins catchment area. The law is that they're supposed to be transported to the nearest emergency facility for a variety of reasons. You want to decrease time in police custody for a couple of reasons. And you also just want to get someone as quickly as possible to an emergency setting. And you don't want to overburden any one setting. And so it's important to recognize some of the data that Dr. Lewis referenced, the study, looking at how many of those 506 that Dr. Cataldi surveyed came to the nearest hospital. It turns out that although there are some EPs where we weren't sure of the address, of those 506, only 171 of them should have come to Hopkins. So a lot of them are going to other hospitals. And in fact, I'm just looking at some I can't share my screen, unfortunately, but I'm looking at some of her data. And there was 13 of those patients actually passed 8 other hospitals on the way. But hundreds of them passed at least 1 or 2 hospitals. And this is just a map of REPs that you won't be able to, that's not worth trying. If I can share the screen sometime, I would. I will tell you though, when they do if the decision is made in the emergency room to discharge the patient, then they are discharged, and that's at the end of it. They might try to make some sort of outpatient follow-up if the patient's willing to wait for that, but if they're not, then they're discharged. And really importantly, any legally owned weapons that the police had taken when those patients were EP'd are returned immediately to the patient, and they also retain the right to purchase a new weapon unless an extreme risk protection order is filed at that time. This is the ERPO law is a law that's been in Maryland since 2018. And Maryland was the first state to allow clinicians to file these. Now Hawaii and DC do as well. But of all the counties in Maryland, Baltimore City uses the least amount per capita of these laws. We don't use them. In fact, I've been told by Baltimore City Police when I've tried to file an ERPO that they'd never heard of the law. And that's a problem. A training problem, maybe. But so this is really an important situation because I think one of the impetuses for this meeting was Ricky Walker, the case of a man who was shot by police during the serving of an EP this summer. Ricky, who ended up at Hopkins, had been EP'd 10 days prior to that EP, having been found walking naked and shooting at cars, and basically acting bizarrely and dangerously, and so appropriately EP'd. But at that time, an ERPO was not filed, an extreme risk protection order was not filed, so he was given his guns back, could buy new guns, et cetera, so that 10 days later, when he was EP'd again, having not gotten any better because he hadn't gotten treatment, he was heavily armed, and that was not a great situation. But it was a missed opportunity to use this underutilized law. So anyway, that's if discharged. If admitted, they come upstairs to an inpatient unit like mine. We do a more detailed history and physical than there's time for in the emergency room for efficiency's sake. We follow up on those labs Dr. Lewis mentioned to make sure there's not a medical reason or organic reason for some of the behaviors, that kind of thing. And we treat, most units use a milieu management where patients are in an interactive common room. It's a little bit different during COVID, but that's the general idea. There's, psychiatrists and nurses, and usually medications are restarted or adjusted. And when they're deemed, either they're deemed safe to go, or if they're a voluntary patient by that point, if they decide to go, then we discharge them, but with outpatient follow-up. That's probably the most important thing we do on the inpatient unit, to be honest, is making sure there's somewhere for them to go from the inpatient unit, someone to keep seeing them. Because it's that window when someone leaves inpatient before they get into outpatient where people slip through the cracks and get into trouble, hurt themselves or others, or end up right back in the hospital, for that matter. And so we try to arrange group home. If there's nowhere for them to stay, we really do everything we can not to discharge to a shelter. That's the absolute worst case scenario. Try to find, sometimes when it's appropriate, when drugs are involved, we'll have get someone to rehab. As you heard from a parent earlier, that can be really hard when it's an adolescent. I deal with adults, but I am aware of the fact that for adolescents, inpatient rehab, especially with comorbid psychiatric illness, is difficult, to say the least, as you heard earlier. For adults, there are options, especially for male adults. But anyway, so that's what happens on the inpatient unit, essentially. I think that if I were to make some suggestions for maybe ways to improve this system, a couple things come to mind. I don't want to use up too much of your time. I think, as has been said by a few people today, this is not a job best suited for police. It is outside of their skill set in a lot of cases. It's a lot to ask of officers who are not mental health specialists. However, there are times when there's an element of danger that necessitates the presence of someone trained in the use of force, as many psychiatric nurses are. When I started residency, we're all trained in different ways to wrestle someone down without hurting them. I think it's a very rare situation that would necessitate the use of live ammunition. I feel like that, not being an expert on the interaction between the police and the patient at the scene, because I don't meet them there, it does seem to me like live ammunition is probably a bad idea to go in with for the patient or for the police. And so getting those things, decreasing the amount of live ammunition accessible by the patient, are things like ERPO laws, access to weapons, lots of things that can be handled on the city level, as opposed to some of the things that we would address that would be more of a state or federal thing to increase access to care, for instance, that kind of thing. I think it would also be great to have a data collection system for emergency petitions, emergency evaluations, so that when we present data like this, it wouldn't just be who we happen to have at Hopkins, we could get a citywide. And actually, the Maryland Institute for Emergency Medical Services Systems is equipped to do something like that. If tasked for it, the MIME system could really track those in a way that would be useful, because then we could have data to show how long people are in custody, racial disparities in who is EP'd and how it's handled, a variety of things, but we need the data to then move forward with that. I'm a public health researcher, and so I'm used to getting big data sets to then look for ways to improve a system, but without that data, which is relatively cheap to collect if it was implemented, it'll be a good, easy step. And then, of course, I'm on my soapbox about guns. And so increased education, training, or utilization of the extreme risk protection order in Baltimore City specifically, to catch up to places like Anne Arundel or Montgomery County, would reduce access to firearms for those who have been historically a danger to themselves or others, people that have been hospitalized or have been identified by family members, police, or their psychiatrists or mental health worker to be someone who probably temporarily, at least, shouldn't have a gun. And so those are sort of just three quick suggestions. Happy to talk more if there's time later, but thank you for having us on the panel.
Thank you. That was incredibly helpful in helping us understand the process. Before I go to committee questions, I did have one quick follow-up. The process that you laid out from intake to follow-up, is that a universal process across the hospital system in Baltimore City, or are hospitals tasked with developing their own protocols, or just trying to get a better understanding of this is all the first time I'm hearing this full process, so that was just my sort of immediate thought. Is this a Hopkins thing, or is this how things are done across the state?
That's considered best practice. Oh, sorry, Cynthia, go ahead.
Oh, I was going to say that's a great question, and it really, an evaluation can take different forms at different places. Again, we're fortunate that we have a psychiatric emergency service within our emergency department. The goal for most places would be for someone to get labs done, someone to get a urine toxicology screening to see what their alcohol level is, and to get some type of evaluation which really speaks to the things like their past psych history, their medical history, their substance use history, so any physician, it doesn't have to be a psychiatrist, can do that. So the evaluation, and honestly, we see so many repeat emergency petitions that we will see someone say, oh, we just saw them like yesterday, so they don't have to maybe go through the whole everything, because we know them so well, we have records. So the goal is for a good evaluation, and most places should have physicians in place who can do a good evaluation. But if you have psychiatrists there and mental health professionals, we're going to be able to take it to another level to do more of a formal psychiatric evaluation. But to evaluate someone's safety, physicians are able to do that. Paul, did you have anything to add?
No, I think that I totally agree. And as far as past the evaluation stage, the inpatient and then discharge stage, most places use a milieu management, this kind of thing, and try to have a good setup for when someone's discharged. I know from experience with patients that have been in other inpatient units that sometimes that's not able to be done. Resources are very scarce. And so sometimes I hear other places more commonly discharging to code blue or to shelter, unfortunately. But sometimes there's not a choice. So we all do our best. And I think one thing I might say might be a little different about Hopkins just in terms of this process that might play a role in us getting a higher proportion of people that are outside of our catchment area is that most other emergency rooms, I think, have the police wait with the patient more than we do. We tend to not really want the police back in the psych emergency room for a couple of reasons. One is that they're armed, and that's not a great situation in the psych emergency room. And so we just accept the patient and then the police leave, which is preferable to a police officer compared to places where they might be asked to stay until an evaluation is done, which could be like 6 hours. So that might drive a little bit. There's a couple things that might drive it, but that's one difference in Hopkins that might be relevant for this conversation.
Yeah, and I would add that we don't allow police officers in our PES area, but they can be in the emergency department with their weapons. So, Paul, I'm glad you brought that up. And did want to make the distinction, too, that there's a difference between people who are in custody who are brought to the emergency department for evaluation of chest pain or suicidal ideation, but they are in custody. We have to make the distinction. You're either an emergency petition patient that's been brought into the emergency department on an emergency petition versus you're in custody where the police then stay with the patient on the medical side where they're evaluated, and then they're transferred to the correctional facility where they have mental health there too. So if this was a longer, a discussion for a different day, us really partnering with, we've got the hospital, the police, and the correctional facility, because oftentimes patients are brought on an emergency petition after committing a crime. And finding the appropriate place for that person, it really shouldn't be the correctional facility. But we can only do so much. When we evaluate someone who might have destroyed a store, in the setting of, they were upset, but they have a history of bipolar disorder. If they come to us on an emergency petition and they're now calm, they're not exhibiting symptoms that are, showing that their illness is acting up, and they're able to say, look, that happened, I was upset, or what have you. We're not, we're not correctional officers, so we are physicians, and so our duty is to evaluate for that mental health, the mental health aspect of it. And it's not our duty to then our policy is we don't then call the police up to say, oh, we just evaluated the patient. Now, if there's a charge, no, the distinction has to be this person is either under arrest and being evaluated for other medical conditions, whether it's as being suicidal, what have you, versus they are here on an emergency petition. That's a whole nother discussion, but that's a place where we need to tighten up how we can get resources to get that balance where that person doesn't necessarily need to go to jail, but being in an emergency department and then, not going into an inpatient hospitalization, then they're discharged and potentially able to continue, repeating the cycle. So there's just so many angles that could be addressed in this conversation.
Thank you. Are there other questions from committee members or council members? Councilmember Cohen.
Thank you, Mr. Chair. And thank you, Dr. Lewis and Dr. Nestat, for a really clear presentation on the system at our hospitals. So, we know that there's been challenges related to discharging patients. This was not a Hopkins incident, but I do remember a little while back, someone was essentially unceremoniously dumped in the streets that was still suffering. I believe it was in West Baltimore, and was just sort of left. And just kind of the lack of basic humanity in that interaction was really concerning. So I'm interested in, one, sort of the continuum of care. And after someone is discharged, after the petition is closed out, what additional services are provided to prevent them from repeating, relapsing, right? I mean, we know that folks who are struggling with addiction or substance use disorder or trauma or any of these things, 36 hours in a hospital isn't gonna fix it. They may be able to attain immediate sobriety in that moment, but 9 times out of 10, and I would imagine even much higher percent than that, they're coming right back, if not escalating beyond that. So I'm curious, like, what the follow-up and continuum of care is, and assuming it's not as good as we would want it to be, what would it look like for a sort of more comprehensive continuum of care for people that are suffering with mental health crises?
I'm glad you asked that. And I will say that there's been a huge difference when I was directing the emergency department like 5 years ago, and now that I'm back. We now have psych social workers who are emergency psych social workers embedded within the emergency department. We have our peer recovery team, where they are these are peers who have often had addiction in their past, but are now working in the hospital setting, in the emergency departments. Anyone who wants substance abuse treatment can get it. When I was a resident, 20 years ago, we did not have a lot of resources in the community. So now there are a lot of resources. I think the opioid crisis has allowed dollars to go to places where patients can go for 30 days, 60 days, 6 months, a year. They can get mental health dual diagnosis treatment. So there is a pathway for that patient who wants that help. Also, our social workers, we no longer, when we discharge patients, it's almost like we're a mini short stay. Our social workers, we will get patients group homes from the emergency department. We will get beds, with COVID, everyone has to have a name to that bed. So we will get outpatient treatment. Our job really, it's not like it used to be where you're discharged and you're kind of on your own. We do many of the things that the inpatient units do to provide that. I think the biggest problem is you have a huge population that you do not, they don't have to accept care, so if they're considered not a danger and don't need to be committed to the hospital, they don't have to accept care. We've got a homeless population that will get their disability. They don't want to live in a group home where they have to give up most of that $700 a month, where they can get a safe roof over their head. So they want to be able to use that money, utilize the shelter systems, or kind of be independent in that. So what we're finding is a lot of patients who come in, they might get admitted, they take the medicines while there, they detox, they get better, they get out, and we do not in Maryland have a mandated outpatient commitment system. I know that there's, I think, a pilot project and people are working on that, but I think that is what is a huge part of the missing piece, that patients, there has to be, before, like the state hospitals, although they were de-institutionalized, but there is a balance. We've got a huge population where they come in, they get discharged, they go right back to doing the same thing, and they're not getting better. And they're one day going to harm themselves. But we can't force them to a state hospital because state hospitals don't have any beds. There's usually a forensics pathway. But I think there needs to be more thought into patients who are failing, patients who are presenting to the emergency department 20 out of 30 days, coming in, utilizing a whole lot of resources, but then there's no consequence when they keep doing the same thing. So, and helping them to understand the benefit of staying in treatment. There's no mandated outpatient treatment. And I think that's where, we need to look at how we can thoughtfully do that and help people to understand the importance of it. Because it's like we're chasing our tail. It's almost like we're enabling this by allowing this, to be quite honest.
I think there's a lot that needs to happen, but it's a lot of it's on the state level, not much the city council can do. As I find myself in Annapolis a lot about these things. So, for instance, the way that that medical assistance is handled. I think within the city, though, there are great agencies that I don't know how funding works. I'm just a simple country doctor, but I feel like if there was the ability to funnel more money to places like BCRI. I know you have BCRI testifying later on. I don't know if Edgar's on the call, but they do amazing work, and they're limited just by the resources they have in terms of both the mobile crisis teams, but also their crisis beds where people can be temporarily. I mean, they make the system possible. Anyway, Healthcare for the Homeless is another organization that I don't know if they get city funding, but wow, they're fantastic. In fact, one of my best friends was in North Carolina, needed a psychiatrist, and said, "Hey, I'm moving to Baltimore just so I can have a good psychiatrist. Who at Hopkins should I go to?" And I'm like, no. Healthcare for the Homeless. That's where you need to go. Fantastic organizations that can help with that outpatient part of it. I'm really sorry. There's lots more to talk about. I actually have a 3:30 patient, so I have to go. But I appreciate being on the panel. Thank you, guys.
And I did want to say, Paul, I'm glad you mentioned BCRI. I know there's some representatives here, but they have been in a tremendous, I mean, they again allow us to decompress the emergency departments and take patients who, who are willing to be treated, who want the help. There are a couple of other crisis facilities as well, but it's great for us to have avenues where patients who might not need to be involuntarily committed or aren't ready for just discharge, but avenues to get them proper treatment and get them supports. And BCRI has been tremendous for us, I must say, as well as others.
Maybe the last thing I'd just say, the Maryland Psychiatric Society, I'm biased, I'm on the executive board, but is a great resource the city council might want to think about tapping to get more information from outpatient, inpatient, a variety of psychiatrists in Baltimore. Even though it's the Maryland Psychiatric Society, it's really largely represents Baltimore clinicians and their patients. And we would be happy to have any representative come to our meetings or anything like that. Anyway, thank you so much. I'm sorry that I have to leave early. Thanks. Bye.
No, thank you, Paul, and thank you for your testimony, and Dr. Lewis as well. Amen to what you said, in that I do think we are in a situation where we are cycling people through in a way that is often not advantageous to their health or well-being. And would just say briefly that my wife's a psychiatrist in Cherry Hill, and the experience that she describes is of folks coming in again and again and again for treatment, but not always getting the long-term care to deal with the underlying trauma or whatever else it is that is driving some of the behaviors, some of the other issues. And so I do think that piece is really, really critical for our city.
Agreed.
Thank you. Are there any other questions for this panel? Okay, seeing none. Thank you all again for making time for us. We are going to move to testimony from city agencies. And we're going to start with the Health Department, Mr. DePaul Niver.
Thank you, Mr. Chair and members of the committee. DePaul Niver on behalf of the Baltimore City Health Department. I would like to begin by thanking the residents and providers during this hearing that have provided testimony. They've documented some often harrowing experiences, and I would like to reiterate that within the health department, we believe that residents should be able to access care in a safe and empathetic manner. With that said, as many on the council know, public health services in Baltimore City are bifurcated, with our partners at Behavioral Health Systems Baltimore providing mental health and behavioral health services. And given their very sensitive work on this very subject matter, we are deferring to their testimony. So as noted in our agency report, we have no objections to this, but we truly believe that this is a necessary conversation. Thank you.
Thank you. Are there questions for the Health Department on this? Okay, seeing none. We're going to go to the Baltimore City Police Department, and there will also be on this panel representatives from the Behavioral Health System of Baltimore. Not sure how they use this panel. I guess I'll just name everyone, and you can go in that order. I'm not sure, Michelle, did you have a preference? or presentation that needs to be.
If you like, Mr. Chairman, if you'd like me to jump in there, I'm happy to do that. If that'll make it simpler.
Yeah, so if you'd like to jump in, we can start with you. I do know the first three folks on my list are from BPD. I have you, Major Martin Bartness, and Paul Mincerelli. So I guess let's start with BPD, and then we can go over to EHSB, Adrian Bredenstein and Carrie Graves from NAMI, Metropolitan Baltimore.
So, Mr. Chairman, thank you very much. Michelle Wurzberger, for the record, Director of Government Affairs for the Baltimore Police Department. We have a joint presentation. So it's kind of a hybrid panel between us, the Health Department, and the folks you mentioned. So for BPD, we do have Major Martin Bartness, who is in charge of our Education and Training division. We have Paul Mincerelli, who is a compliance supervisor with the Consent Decree Implementation Unit. We have Adrian Bredenstein from Behavioral Health System Baltimore. We have Carrie Graves, who is the Executive Director of NAMI Metropolitan Baltimore. Just 2 points before I turn it over to Major Bartness. We did, the Commissioner Harrison wanted very much to be a part of this hearing. If you don't know, there were hearings announced on police reform initiatives in the Senate Judicial Proceedings Committee that is actually going on right now. I have 2 different computers going on to keep an eye on both hearings. The commissioner is testifying in the Senate right now. In his stead, we are going to have Deputy Commissioner Danny Murphy, who is in charge of the Compliance Bureau. He is finishing up a meeting and will join us as soon as he is finished. With that, I'm going to turn it over to Major Bartness.
Thank you, Michelle, and good afternoon, Chairperson and Councilmember Cohen. Thank you for the opportunity to speak to you today on this important matter. I want to also thank those with lived experience who have shared their experiences with the Baltimore Police Department today. It is through those shared experiences that we have an opportunity to learn about what is occurring in real time on the street and how our policies, practices, and training need to be changed in order to more effectively serve the community. So thank you very much for sharing those experiences, painful as they may have been. Those shared experiences also demonstrate very clearly the complexities of these calls for services and the needs of the community. And we, as the police department, understand what Councilman Cohen expressed in his introductory remarks today, and that is cops play too great a role in responding to those in crisis and with behavioral health needs and substance use disorders. And that is to say that we fully support the recommendations that have been made today, and we're all collectively looking for the clearest path forward so that we can respond to the community's needs in the most effective manner. We understand that police often aren't the ones that can provide that most effective service. We do play a role when public safety is at risk, but otherwise, we want to do what we can to divert calls to the behavioral health system. We don't want to criminalize those who are living with these challenges. And we want to increase and encourage connectivity to community-based services. I want to spend a little bit of time today telling you about what the Baltimore Police Department is doing in the area of training as we endeavor to respond in the most appropriate manner when we do receive behavioral health calls for service. Our data aren't great at the moment in this particular area, but it's estimated that we respond to about 14,000 behavioral health related calls every single year and are involved in the service of about 2,000 emergency petitions. So it's a significant workload. We are currently engaged in developing and delivering a number of different training courses related to behavioral health. For our new recruits, we provide a 3-day course on behavioral health awareness. For our veteran personnel, every year, we provide 8 hours or 1 full day of training on behavioral health crises and response. We are just beginning now to deliver a new course for police dispatchers and 911 call specialists on behavioral health awareness and diversion of those calls to behavioral health professionals. A fourth program that is currently underway in collaboration with our many partners is a 1-week crisis intervention team training. These crisis intervention team officers are going to be specially trained, and they are going to be the first ones to respond to 911 calls for service when a member of the public calls and indicates suicidal ideation or indicates some other type of behavioral health crisis to which police are being called to the scene. We want to get those officers with the additional level of training to the scene around the clock, 24/7. And so our goal will be to initially train approximately 1/3 of all patrol officers as CIT officers, equally across the districts and shifts, to ensure that level of expertise is available. We have a crisis response team. This is a small unit. It's comprised of 1 sergeant and 3 officers, and they respond to the most acute calls for service and do follow-up with a licensed clinical social worker from BCRI. And then finally, to address one of the comments that the physician from Johns Hopkins made about the ERPO law and how it is perhaps not being leveraged as effectively as it ought to be in Baltimore City. Yesterday, as a matter of fact, we filmed with our media relations unit an e-learning on crisis response. This training that I just outlined for you takes a long time to deliver. With almost 2,500 sworn members, to go through, to get everyone through this much training takes an extended period of time. We hope to be through all of the initial round of training by the end of next year. As an interim training method, we are producing this e-learning that it's going to make very clear to officers the resources that they have available to them through mobile crisis response with BCRI, to the Here to Help hotline with BCRI, to the various community-based services, to our crisis response team that is working 7 days a week, 11 a.m. to 7 p.m., and make sure that they can tap into those. We have a mobile app on every police officer's phone that provides the telephone numbers to a number of behavioral health response services that we also want to encourage the officers to use. And again, it reinforces the ERPO as a tool that we have at our disposal to keep the public safe. With respect to some of the specific classes that are being taught in these courses, they include such things as trauma-informed care, the history of the mental health system and its roots in some discriminatory practices, intellectual and developmental disabilities, traumatic brain injury, psychiatric medications, working with adults, working with youth, substance use disorders, abuse disorders, and BPD's behavioral health policies. We do not provide this training in a vacuum. In fact, we work very, very closely with many partners through the Collaborative Planning and Implementation Committee. Some of the organizations that have both helped us develop the curriculum and on a weekly basis help us deliver the training include BHSB, BCRI, BCARS, NAMI, the ARC of Baltimore, the Anti-Stigma Project, the Alzheimer's Association, and Loyola University. It's very important that we have these partnerships to ensure that we are providing evidence-based training, the most current training possible, and the best quality training possible. And these courses are also co-facilitated. In other words, we are teaching them in conjunction with those behavioral health professionals to make them as real as possible. We believe that in order for police officers to understand that they need to reach beyond themselves to serve the community, we need those representatives present in the classroom for us. It makes it much more real. It makes it much more tangible. They come to know those partners, and then those partnerships are strengthened. That's all I have. I'm going to now turn the floor to Paul Mincarelli, who is going to discuss policy.
Thank you, Major, and good afternoon, Chairman Burnett, Councilman Cohen. My name is Paul Mincarelli. I'm a program compliance supervisor with the Baltimore Police Department. I'm with the Consent Decree Implementation Unit, and I'm overseeing the reforms associated with behavioral health and crisis as it relates to the Consent Decree Agreement. So the Consent Decree envisions the least police-involved response to crisis events consistent with public safety and favors new strategies at 911 and dispatch level, as well as the on-scene patrol level. New strategies that will divert calls towards community resources and away from law enforcement. The Consent Decree Agreement includes nearly 30 paragraphs of specific reforms aimed at identifying gaps in the city's response system, revising the BPD's policies related to interactions with individuals experiencing behavioral health disabilities or crisis, and enhancing all levels of crisis response training, as Major Barnes mentioned, for all BPD members. The decree also prescribes that the BPD participate in a citywide collaborative body known as the Collaborative Planning and Implementation Committee, co-chaired by BHSB and the city, to effectuate these required reforms in policy, training, data, and implementing the recommendations of the gaps analysis report. But I'm here specifically to talk about policy. So in 2019, the Baltimore Police Department revised or drafted anew 3 policies specific to behavioral health disabilities and crisis. The policies were subsequently approved by the Department of Justice and our court-appointed monitoring team, and they greatly informed the training that Major Bartness outlined. These policies were drafted with the input of the citywide Collaborative Planning and Implementation Committee body, which incorporates individuals with lived experience, providers, as well as our local behavioral health authority. In addition, the consent decree offers us an opportunity to work with national experts. So we have subject matter expertise at the Department of Justice, as well as through our court-appointed monitor, who has essentially spearheaded an effort to specially train law enforcement officers in behavioral health response. Specific to the Baltimore Police Department and available on our website under draft policies, Policy 712 is our crisis intervention program policy. Policy 713 is a new draft of our emergency petitions policy. And policy 715 is the first of its kind. It is, or first of its kind rather, for the Baltimore City. It is a policy on 911 and dispatch responsibilities for calls where behavioral health needs are indicated. All 3 of these policies are underpinned by 5 core principles, the first being community planning and implementation. As was said earlier, these policies don't exist in a vacuum. Civil rights, that when a member responds, their course of action is conducive and respects the individual's civil rights and expectations under law. 3, community and officer safety. That is the least police-involved response necessary. And the policy outlines steps for protecting member safety as well as individual safety, which I'll get into momentarily. And for de-escalation, all of these policies are written through the lens of de-escalation, and all responses by law enforcement officers, when applicable, are to use their time, distance, cover, communication, seek the most peaceful resolution. Finally, the sanctity of human life. All policies are to follow the BPD's adherence to the sanctity of human life for our mission, vision, and values. But specific to this policy, 712, which is our crisis intervention policy, we have a matrix, if you will, of what a member's preferred course of action should be based upon what they're observing. Criminal behavior, non-criminal behavior, indications of urgent needs, or escalation of harmful or symptomatic behavior. But underpinning all of that is a duty to de-escalate. And where necessary, there is a requirement that you leverage community resources. This is how we effectuate the least police-involved response, through policy. And these policies come to life through training. Our hope is that following successful completion of 911 and dispatch training, that policy 715 will become effectuated. After in-service training, where all veteran officers are receiving 8 hours of in-class behavioral health training. Policy 712, our core policy, as well as the emergency petitions policy, will also be effectuated. So we're hoping that by early 2021, the BPD's policies that we drafted in 2019 will be live and members will be accountable to those requirements. I will now pass it on to Adrian to talk more about BHSB and the CPIC.
Thanks, Paul. Hopefully everyone can hear me. So I prepared a PowerPoint presentation for today, so I'm going to share my screen. Michelle, I see you. Can you see my screen? Just confirm.
Yes.
Awesome. Thank you. So thanks again, Paul, and thank you, Councilman Burnett, for hosting this hearing today. Thank you, Councilman Cohen, for calling this hearing on this really important topic. And I also want to thank all of the panelists that have shared so far, in particular those with the lived experience that shared their stories to kick off the hearing. You're the reason that we're all here today, and you're the reason that we're all working to strive to make our services and our system of care better in Baltimore City. Unfortunately, what we've heard today from both our providers and people with lived experience is not new or rare. We know that as a default, because we don't have robust community-based behavioral health crisis services, and also because we as a society are so conditioned to calling 911 for any type of emergency, that the default is 911 and emergency departments for where people go for care when they are in the midst of a mental health crisis. We are asking our police to do way too much. And I think a lot of the testimony we've heard today just shows us so much how we need to value our behavioral health crisis services system in the same way that we value other emergency services like fire, police, and our emergency department. So, what we heard today highlights the gaps and missed opportunities in Baltimore City's system of care. What I'm hoping to help, cover today, and how I see my role in trying to help with the informational hearing, is to really share with you what we have already in Baltimore City's system of care. And we do have some strong components of what's needed for a robust behavioral health crisis services system. But we know that there is more we need, and we know there is certainly more we can be doing to improve our current system of care. So with that said, very quickly, for those who don't know us, Behavioral Health System Baltimore is a nonprofit, and we serve as the local behavioral health authority in Baltimore City. In that role, we are responsible for overseeing and managing the behavioral health system of care, in particular the publicly funded behavioral health system of care for mental health and substance use services. We do this. We perform this role by partnering with a variety of other system partners like the school system, law enforcement, fire department, court systems, EMS, all of them to try to ensure that there's broad access to the continuum of care of services. So partnership and collaboration is a key function of how we do our work. Just some quick state system context, and we heard about this earlier from some of the other panelists, is Maryland's public behavioral health system is a state-driven system. That's largely because it is a Medicaid-funded program, largely Medicaid-funded program, which sits at our Maryland Department of Health. The Maryland Department of Health has a local arm or a local behavioral health authority in every jurisdiction that they task with overseeing that local system of care. And then that, so that's us, BHSB in Baltimore City, and we oversee all the behavioral health services, and ultimately that's what serves and supporting the services and the overall health and wellness for individuals, families, in our community. Baltimore's public behavioral health system is the largest system in the state, representing nearly 40% of the entire state public behavioral health system. So that is about 78,000 people who are served through our system of care over the course of the year, with expenditures of around $510 million. Most of those, again, are expenditures that are coming through the Maryland Medicaid system. But our role in grant funding services is particularly grant funding services that are not reimbursable through Medicaid. So services like the wellness centers, like our wonderful partners and from Hearts and Ears that we heard from earlier, those are types of services that are not funded through Maryland Medicaid. So we at BHSB grant fund those types of services. We also fund street outreach, prevention services, and peer support services, and crisis services, what we're here to talk about in more depth today. For roughly every dollar that comes into BHSB, roughly 80% goes back out into the community for service. So behavioral health crisis services in Baltimore, like I've said, we have some strong components of what's needed for a robust continuum of care for behavioral health crisis services. What you see on the screen is a framework for what we're driving towards. We want to have those five, the continuum, so those 5 columns, those are the columns that we are driving towards in Baltimore City. And this framework is something I just want to point out that it comes from a strategic plan that BHSB did back in 2018. We went through a community planning process where we got input from providers and people who have used services, behavioral health crisis services in Baltimore City, to figure out what we were missing, what we had, what was working, what needs to be built out more, all of that good stuff. We, in turn, then provided this information to the folks who were doing the gaps analysis for the consent decree work. And one of the recommendations that came out of the gaps analysis is that this framework be fully implemented in Baltimore City to support the city to address the findings, the behavioral health findings in the gaps analysis. So let me try to quickly walk through the components of the behavioral health crisis services that we have in Baltimore City. So first, and you've heard about this already, is the Here to Help hotline. This is our 24/7 suicide prevention crisis hotline. It does a lot more than just crisis services. It's actually the hotline that people can call, not only if they're in crisis, but if they're looking to get information on services that exist in Baltimore City. But our trained callers, our counselors, trained callers can do a number of things when people call in. They can certainly help with people who are in the midst of crisis and deploy mobile crisis teams, which we'll get to those services in a second if that's necessary. They do screening and assessments. They can also make referrals and schedule appointments on the spot. Our call center is open 24/7, 365 days a year. They get over 40,000 calls annually. So other things that the call center does is they do conduct follow-up, in particular for people who are calling the call center in the midst of a crisis. The call operators will then do follow-up to see if that person gets connected to care and what other supports they may or may not need. The other thing I'll note about this is the call center also serves, or the Here to Help hotline also serves as the call center for youth and families in Baltimore City. So people whose children are in the midst of a crisis can also call the Here to Help hotline. It does not always mean that our youth crisis services are available, and I'll get to that in a second, but this is the one centralized hotline we have in Baltimore City for youth, families, and everybody. Mobile crisis teams are another component that we have in Baltimore City. So our mobile crisis teams, you've probably heard me say community-based crisis teams. These are the non-law enforcement crisis teams that are deployed to respond to people in the community. They respond to people on the streets, in their home, emergency departments. And what it is the behavioral health clinician paired with a nurse. Sometimes in other communities, there are mobile crisis teams or behavioral health clinicians paired with a peer or somebody with lived experience. Our model here is a behavioral health clinician and a nurse. In Baltimore City, our mobile crisis teams operate 24/7. However, this is a very new thing. We did not, for the longest time, have a mobile crisis team operating overnight, and that's largely because we did not have the funding for it. So last year, the mobile crisis team responded to 2,500 responses in last year. The mobile crisis team and Here to Help hotline services, they both operate out of the same provider. They're funded by BHSB with state and federal grants at $2.4 million annually. And one thing I'll note, even with our mobile crisis team that responds overnight, like I said, it's a new service that just started in February. They are narrow in scope in that they are only have the ability and capacity really to respond to emergency departments at this point in time. However, we'd love to see that expanded. This other parts of our crisis team, and you've heard Major Bartness talk about this, are our partnership with law enforcement for the crisis response team and also the law enforcement assisted diversion team. Two very different teams, both operating mostly in the downtown area, although the crisis response team is available citywide. Again, these services are grant funded for BHSB through state grants and foundation grants. Another component that we have in our crisis response system in Maryland is the Maryland Crisis Stabilization Center, which is located on the west side of Baltimore. This is a physical structure that provides safe, sobering services for people who are under the influence of drug and alcohol, or if they experience an overdose. So this is a center that's also very narrow in scope, and that's largely because of the funding mechanism that's used for it. It is funded at $1.8 million by BHSB with federal opioid grant dollars. So because it's funded with opioid dollars, that is why it is only focused on substance use. Although a number of people that we see coming through this program have underlying mental health issues. So we are addressing those issues as they come in, but eligibility is focused on the substance use side, unfortunately. The good thing that we're seeing out of this is that we are the program itself is doing a very good job linking people up to care upon discharge, which is what we want to see with any kind of crisis response, is somebody stabilized and then linked to the ongoing care. Around 60% of people that come through the stabilization center are linked to ongoing care upon discharge. And then the other benefit of our program is that it provides 30 days of follow-up case management. So trying to make sure that link sticks and people who are actually linked to ongoing care get to their appointments and get connected to that provider if they have not already been connected or reconnected to somebody who was treating them previously. The next component that we have in our crisis response system in Baltimore City are our crisis response treatment and recovery services. So we've got mental health and substance use services. We've got a 21 residential mental health crisis bed unit. This provides subacute stabilization services. Last year, we served 698 people, and we maintain a pretty high occupancy rate of 90%. Most people in the mental health crisis bed stay about a week before they are stabilized and then linked up to ongoing care and then sent home or to wherever their stable place of environment is. This program, again, this is funded by the state. This is funded with state grants through the Administrative Services Organization, and this is the payer for behavioral health services in the state of Maryland. Same for substance use detox. Those are funded at $5 million, again, paid for through the ASO, Administrative Services Organization, which is through the Maryland Medicaid program. So different sources of funding. Mental health crisis beds are still grant funded. Substance use detox are reimbursable through Medicaid, which is a new service and one of the benefits of the Affordable Care Act that Maryland has taken advantage of here. But substance use detox, we have 3 of those providers in the city. They provide medically managed withdrawal management services for people who are under the influence of drugs or alcohol. And then I just want to spend a little bit of time talking about youth and family services, because it's such an important part of our system, and it is so limited, which you heard a lot about from the testimony we heard earlier today. So we have limited youth mobile crisis services in Baltimore City. Our mobile crisis team provides services to the public schools and youth in foster care. So again, narrow in scope. The services operate only Monday through Friday. So basically roughly during normal working hours is when the mobile crisis team operates. When they are not operating, the adult mobile crisis team tends to be the one that can respond if they are available. The Here to Help hotline offers support to youth and families 24/7. Certainly when the mobile crisis team and the community stabilization program are operating, which again is during normal business hours, if calls come into the Here to Help hotline, they are referred to those services, and the Here to Help hotline makes they make that connection. They don't tell somebody to go, here's a number, call it. They will actually make that warm handoff on the phone call. Again, these services are funded by BHSB with state grants, so none of this reimbursable through Medicaid. So that's a very quick overview of what we have in Baltimore City for our behavioral health crisis services. But I wanted to leave you with where we see a couple of opportunities on the horizon that could help to strengthen our system of care in Baltimore City. One, the consent decree, which you heard about already from Major Bartness and Paul. And the other is the Greater Baltimore Regional Integrated Crisis Services proposal, which I'll talk about in more detail. And then the third being community outreach, engagement and outreach, which is work not just that everybody I think owns in Baltimore City, not just BHSB, but we see it as an incredible opportunity. So the consent decree, as we've heard earlier, the Collaborative Planning and Implementation Committee is a group that BHSB co-leads with the police department to address the behavioral health findings in the consent decree. One of the important tasks that this group helped to lead was the completion of the Baltimore Public Behavioral Health System Gaps Analysis Report, which is a requirement of the consent decree to identify where we had gaps in Baltimore City's system of care. That report came out with 38 recommendations, and recognizing we can't do all 38 things at once, and we work to prioritize or figure out what implementation priorities were. Again, these priorities were developed with CPIC, with input from citizens and behavioral health providers and a variety of different stakeholders. But where we landed with the four bullets that you see on the screen, looking at building out behavioral health crisis services, supporting the expansion of affordable housing, 911 dispatch and diversion, and then expanding the peer recovery workforce. Where BHSB plays a role is in the first and last one, in behavioral health crisis services and expanding that peer recovery workforce. So one of the things that we've been focused on to really expand behavioral health crisis services and a key opportunity is the GBRICS proposal, or the Greater Baltimore Regional Integrated Crisis System proposal. This was a grant proposal that BHSB developed in collaboration with a variety of stakeholders. This was probably one of the largest collaborative processes we've ever worked on, with 17 hospitals, 4 other local behavioral health authorities, philanthropic support, input from people who have used our crisis services system, not only in Baltimore City, but in Baltimore County, Howard County, and Carroll County, input from providers. So this whole planning process to develop the GBRICS proposal was over a year. It took us over a year to develop it, but we did submit a grant proposal to the Health Cost Services Review Commission, which is a state commission that is the overseer and regulator of hospitals in Baltimore, or hospitals in the state of Maryland. For those who may or may not be familiar, the hospital system in Maryland is an all-payer system, so our state regulates them and sets their rates for care. One of the things that they do is they build in dollars into the hospital's rates that they expect the hospitals to invest in community-based services. One of the things they want to see them invest in is behavioral health crisis services. So we took this as an incredible opportunity to partner with not only hospitals, but a variety of other stakeholders to strengthen our behavioral health crisis system. What the HSCRC wants to see is they want to see their dollars invested in infrastructure to stand up behavioral health crisis services, which is something we are lacking not only in Baltimore City, but really across the state, and in services that can be sustainable after 5 years. So what you see on the screen are the proposal elements that we have submitted. If this is fully funded, this will bring $45 million over 5 years to really invest in, again, our behavioral health crisis infrastructure and expansion of services, in particular those mobile crisis teams, which you heard from David earlier about how important a role mobile crisis teams can play if we have a robust crisis services system in really preventing people from having unnecessary interaction with our police and also in our emergency departments. And one thing I'll say is thank you, Councilman Burnett, for your support of this project. We appreciate the letter of support we received from you and City Council President Scott. Although we are still waiting to hear if this is fully funded, we are still very hopeful that it will be, if not fully funded, partially funded. And then the final opportunity is just community engagement and outreach. So one of the things I mentioned earlier, and just kind of framing up one of the big challenges that I think we in Baltimore City experience, but it's not unique to Baltimore City, is culture change. And that is that we are so conditioned to calling 911 or using our emergency departments for any type of emergency, in particular behavioral health related emergencies. So helping people and helping our community to, one, be aware that there are alternatives alternative services and alternative access points out in our community besides 911 or ED takes culture change and community organizing at the grassroots level. So some of the things that we've been doing and partnering with a number of people who are in this hearing today is having community forums. One of our most recent one was behavioral health, police reform, and the consent decree. These community meetings, we talk about a variety of issues, but it gives us the opportunity to point to the alternative system of care that is out there and the alternative access point, mainly the Here to Help hotline that people can call to instead of 911 or instead of the emergency department for help. So that's one of the things that I think is critically important, and I just didn't want to leave today without pointing out this is an opportunity, the community engagement and outreach piece that I think all of us can own and work on, because it's a big system change and it's culture change, and it doesn't rest with any one entity or any one individual or any one community, quite frankly. So with that, I'll end my presentation, and I'm happy to take any questions, but I think I'm actually to turn it over to Carrie before we do that. Is that right? Yep, Michelle's nodding. So thank you, and I look forward to more conversation. And I can stop sharing my screen too.
Thanks, Adrian, and I will just echo the thanks to you all for hosting this important conversation today and for inviting us to come along. So I am the Executive Director of NAMI, the National Alliance on Mental Illness, Metropolitan Baltimore. We are the local affiliate serving our community in Baltimore City and Baltimore County. NAMI is the nation's largest grassroots mental health organization. We offer education, support, and advocacy services to help improve the lives of individuals who are living with mental health conditions, their family members, and communities. All of our programs are non-clinical services, and they're designed to complement behavioral health care that each participant is receiving. And it's important to note that our classes and support groups and public presentations are all peer-led by trained volunteers with lived experience. So volunteers like Tevis, I'm sorry that she's not on the call anymore, but she is one of our dedicated volunteers, and they're trained to share their story in the community to help break down stigma. They understand mental illness firsthand because they've been there themselves. And so they use their own experiences to help our program participants work towards recovery. NAMI believes in help, not handcuffs for people with mental illness, which is a sentiment that's been echoed throughout the call today. We're committed to the principle that all individuals, including people of color and people with mental illness, should be treated with respect, dignity, and deserve equitable health outcomes and full inclusion. Again, just to echo what has already been said, our mental health system provides too little, too late. And then law enforcement steps in as first responders in mental health emergencies. If we're going to change outcomes, we have to disrupt or change the system that puts police at the forefront of crisis response. But this is a complex problem, and it's going to require complex solutions. And so, while we work towards a system that provides mental health response provides response to mental health crises, we can't afford to ignore the role that law enforcement still plays in this effort. That's why NAMI has long supported crisis intervention teams, or CIT, as a model that has inspired communities and law enforcement to help make crisis response safer and more compassionate, focused on connecting people to care. We've promoted training in mental health and de-escalation for law enforcement. We've advocated for changes in agencies' policies and procedures, and we've pushed to create community partnerships that divert people from justice system involvement. We know that officers trained in crisis intervention can be lifesavers, but they are also a reaction to a fundamental flaw in how we respond to mental health crises. So, instead, the answer needs to be investment in a comprehensive mental health care system that demonstrates cultural competence and equitable treatment. We have to partner with law enforcement to vastly improve the interactions that still improve. But we also have to work to effect the significant change that is needed. And I think you heard some of that change from Adrian just now. In 2001, we began our mental health training program with the Baltimore Police Department and have continued that ever since. We partner with various other community partners to provide training modules. We've historically led 2 modules in our own voice and virtual voices, but have since revamped those modules. And as you heard from Martin Bartness, we are currently working on 911 dispatch training and other modules that are being recreated and revamped. Since 2017 alone, NAMI Metro has trained over 800 Baltimore City police officers. In 2017, we were asked to join the Collaborative Planning and Implementation Committee. And, you know, we're proud to be a partner in all of this process. The Department of Justice has requested meetings with NAMI Metro staff on 3 separate occasions to better understand the community's needs. Our volunteers and participants have been included in focus groups for the gaps analysis study that Adrian mentioned, which seeks to identify those service gaps in the public behavioral health system. We are fully committed to participating in CPIC. 2 staff members regularly participate in monthly meetings of the CPIC and its subcommittees. We engage our volunteers, both peers and family members, every step of the way to make sure that we're getting feedback from them as we go. And while we've increased our engagement and frequency of training since 2017, there's currently no city funding to provide support for our police training services. So to put this into perspective, we are currently donating over 15 hours worth of staff time per week to implement these programs. So we are putting an extraordinary amount of staff time and effort and energy into this because we believe in the change that it can make. But we are lacking that funding to be able to drive this forward in a more effective way. We value the partnership that we have with the Baltimore City Police Department. Graduates of the program have noted that the experiential nature of our trainings humanizes the experience of mental illness. We've worked with the Baltimore Police Department in different ways over the years, but the feedback has always been consistent that NAMI's presence in cadet and experienced officer trainings is powerful and transformative. And so we have faith in the process that the CPIC is following to reform police interactions. But again, I'll just leave it here that I want to reiterate that we can only move as fast as system resources allow, and that funding is desperately needed to ensure success of all of these programs.
Mr. Chair, with that, we have been joined by Deputy Commissioner Danny Murphy, who would like to address the committee very briefly, if that is okay.
That's fine. Thank you.
Thank you, Mr. Chair, members, and our partners today. Sorry I'm a bit late. You've already heard from 2 members of the Baltimore Police Department, so I'll keep it brief. I just wanted to join to reaffirm our commitment to this process and building the best possible system of care in the behavioral health realm in Baltimore. As you heard earlier, I'm sure we're retraining all of our officers with the help of our community partners to ensure that they bring the best possible services when the police are in fact called. But we also know that there's a great opportunity here to reimagine what this behavioral response system looks like. And the consent decree drives directly at that with this gaps analysis, giving us firm ground to engage in really substantive ways in this reimagining conversation. And we look forward to working with all of our partners, community and city agencies to build that best possible system of care where we go towards the least police-involved response to these kinds of incidents and just build the best system of care for the community members here in Baltimore. We had very similar reforms as part of the New Orleans Police Consent Decree, and with the help of partners like NAMI and others down there, the training was something that the officers had said that they wish they had had earlier in their careers, and that it was so helpful. And the family members and the people in the community who had behavioral health issues said it was like dealing with a different police department. So these reforms, these retrainings holds great promise for us elevating the BPD's services to the community, but we recognize there's a much bigger conversation about how we build a better system and what role we play within that. So I appreciate everyone taking their time today to talk about this really critical topic, not just in police reform, but the health of our cities and the wellness of our communities. I said I'd be brief since everyone has talked already. So that's it for me, but looking forward to participating in the rest of the conversation.
Thank you. Thank you for all of you for the helpful information and presentation. Looks like Councilman Cohen, you have a question. I saw you unmute yourself. Go for it.
Yeah, thank you, Mr. Chair. And let me just start by thanking everyone, that entire panel, for your work, your dedication, and for your willingness to participate in this hearing and to be part of a solution. So it feels like calling what we currently have a system of care is a bit of a stretch. And what I mean by that is that it feels like, at least what I heard today, is a lot of external partners that are mostly, if not exclusively, grant funded, sort of doing work within our city. I didn't hear much from our health department. I heard a fair amount from our police department. And what I heard from both Major Bartness and Deputy Commissioner Murphy, by the way, I appreciate both of your candor and the work that you're doing in relation to the CPIC. But what I heard you both say, Major Bartness, you started your remarks by stating you believe police are overly involved in mental health crises, and Deputy Commissioner Murphy, you just said that we want to see the least police-involved response. And yet it seems like still much of our response is police-driven. We are attempting to improve the internal systems to make it a more thoughtful, compassionate response. But fundamentally, unless I sort of missed it, it does still feel like much of our work is police-driven, that there isn't sort of a centralized Baltimore City strategy. I heard Carrie, whose work I've become familiar with lately, who does absolutely great work with NAMI, say that we, the city, don't actually provide any support for the work that they do in training officers. So again, it sort of feels like as a city, we are somewhat ceding the space of handling mental health crises, our responses to mental health crises. And again, I do appreciate the work that BHSB does. It was really good to hear Dr. Lewis mention the crisis response team. But again, we know that they're not available 24/7, that in some, if not many cases, and we've heard a few already on this call, and I've had my own experience as well, that they are not able to send their team out. So it feels like we are piecing together a number of pieces, largely grant-driven, without sort of a major centralized strategy. And it also feels like we remain heavily police-focused. And I just want to lift up a tension that I feel, which is that, I do think we have a leadership within our department that is genuinely committed to the project of reforming the police department with CPIC, with the consent decree as sort of the North Star and the guide. But yet, I think we have all said on this call, in this hearing, that a police-heavy response is not the right response. And so, there was some back and forth during the budget hearings this year about the question of moving funds from the police department. Some people say defund, some people say invest, divest, some people say reimagining. But I think fundamentally what it comes down to is we can't sit here and say that we want a least police involved response and yet continue to have the highest per capita funding for our police department of anyone in the country. And simultaneously, again, this is where my remarks started today, is that I think we have failed, all of us collectively, but elected officials in this city have failed, in that we've built this system as well. We have been the ones who have said, and I will say that I think many of my colleagues, led by President Scott, have moved away from this verbiage. But if you see something, call 911, right? Like the messaging that elected officials in this town have put out consistently, that people have heard and internalized, is any problem is a 911 problem. And fundamentally, I think we've seen and we've heard today over and over and over again just the absolute limitations of over-reliance on our police department to solve mental health crises. So I guess two questions here. Major Bartness and Deputy Commissioner Murphy and Major Wurzberger, again, appreciate your participation on this call and your work on reform. I'm curious how you see the potential of directly moving some of this service out of the police department. And that does cost money. That would mean divesting some of the money that we are currently putting into the Baltimore City Police Department into other services like NAMI, like our health department, who I believe should play a much stronger role in the work that we're doing. I'm just curious sort of how you all are seeing and whether you would agree that if we are driving toward a least police involved response, that part of this is about shifting resources and shifting dollars from the department. I realized I was not clear about who I was directing that to. So maybe Major Bartness.
Councilman, if I may, I do believe this is more of an executive level response. Sorry, Deputy Commissioner Murphy.
That's it. That's okay. So Councilman Cohen, you're bringing up a lot of good questions on this. And like you said, it does harken back to the conversation that you and the commissioner had during the budget hearing. And I think he provided some kind of metaphor about like building the next system before we start dismantling the current one. And I think there are a lot of details that need to be thought through about the gaps analysis points towards this, of what exactly is that system and how do we get there. And the city has a collective conversation needs to have about what is the best use of the limited funds that we do have. But there are going to be a lot of details that have to be determined in collaboration with our partners on this. But yeah, I mean, we have to have real conversations about all these kinds of topics to build the best city we can.
I appreciate that, Deputy. I would reiterate, as I did in that hearing, that it feels like, for the bricks metaphor, that we just keep putting on bricks again and again and again, and that budget goes up and up and up. And if we are truly invested in building a system of care that is least police involved, that really moves the burden off of your officers to do clinical or community-driven work to support the mental health and well-being of people, I think we all need to be very serious about partnering in that kind of way. To Adrian Bridenstine, again, really appreciate your work at Behavioral Health Systems Baltimore. You had mentioned GBRICS. You also mentioned the Stabilization Center. I'm wondering, and in both cases, heavily grant dependent. You mentioned the Stabilization Center, sort of, it is what it is in that it's not what we would want it to be. I know that there are many advocates who believe it should be more robust, more sort of community driven, but I'm curious from your perspective, what would it look like if we actually, and by we I mean the city, actually funded these types of services commensurate to the need that we see out here in Baltimore?
Thank you. I'm not on mute, am I? No, I think I'm not. Okay, thanks. Thank you for that question, Councilman Cohen. It's a good question, and to answer it, I would want to see the funding to create its services to be integrated, because as you pointed out, the example of the Stabilization Center, it's so narrow in focus, and it's because of the funding source. Frankly, it's because it's grant funded. If these services were covered by insurance, like how we heard from Ms. Taylor, if her insurance had covered those services, she could have gotten the care for her service or for her child. And so part of it is advocating for that change at the state level, not just at Medicaid, though, which is, I know Medicaid's kind of more my wheelhouse, and it's what funds this public behavioral health system, but private insurers also do not cover behavioral health services at the level that they cover other healthcare services. So it's an equity issue, as Ms. Taylor pointed out, but it's also a parity issue. They're violating the federal parity law, and the state has made very little progress to advance the parity law here in Maryland. And that's a whole different conversation, but that's an issue. But getting insurers to pay for these services would be the one way to make them more robust, ensure that they're integrated and that they address both mental health and substance use disorders, and not relying on our grant dollars. And then we can use our grant dollars for other services that are non-medical services that we know will never be covered by any type of insurance. So I don't know if that answers the question or not. If the city were to want to invest their dollars in behavioral health crisis services, certainly the Here to Help hotline would be one opportunity. The mobile crisis would be an opportunity. The Crisis Stabilization Center. And I think all of that could, in the end, be stopgap until we could get insurance to cover those services, which is a long haul ahead of us. I think that's going to require leadership change at the state level, certainly leadership change at the federal level, until we would see that kind of policy change.
Thank you for that. To Paul, if I could just ask you, just to frame a little bit as well, just sort of how the health department, I know that we work closely in partnership with Behavioral Health Systems Baltimore on a lot of our behavioral work, but just sort of a little more from like, how does the health department sort of view its system of care within Baltimore for mental health crises?
Well, I'd like to start off with just a little bit of background. So BHSB was essentially splintered off of the health department because they were providing rec services and were looking for Medicaid reimbursement. And all of this was easier if they were run as a separate entity. But when they were created, and Adrian can obviously speak much more to this than I can, they were essentially intended as a quasi-entity. So our health commissioner sits on their board. We're heavily involved in a lot of their committees. So when there has been consent decree talks, we've been aware of them. Whenever there's been advocacy on the state level, we have coordinated. And so we tend to think of ourselves as very closely ingrained with one another. Essentially, we are complements of one another. So I'm sure you're aware of all the functions that occur at the health department, everything from food service facility inspections all the way to our COVID-19 response. But behavioral health is very specific, and it's very involved, and it requires a level of dedication, especially when we're talking about substance abuse disorder or any other sort of mental illness. it requires its own build out. And so it's one of the reasons that we're structured the way that we are. And again, we do absolutely look to collaborate with BHSB whenever there's an opportunity. And a lot of our funding is sent over to BHSB in the form of a grant, but really it's a matter of clockwork because we really believe that we're just keeping them in. We're really just operating in due course. They are a natural offshoot of the health department, although they act with autonomy.
Can I just add one clarifying historical point? So
Yep.
BHSB we were actually created through the integration of two separate nonprofits, BSAS, who maybe you're familiar with, and BMHS. And those were two separate entities established by the state, again, to oversee the system of care. So we've always been independent, both entities, and just were integrated back in 2018 with the state's effort to create a more integrated system of care for both mental health and substance use.
And I should also note that we are slightly different than a lot of other larger jurisdictions in that we do have the separate system of behavioral health from other public health services. In a lot of other counties, you will see them kind of housed under the same umbrella, but at the same time, they also have health departments that are not as autonomous as Baltimore City's. So a lot of their health officers are actually state health employees. So it's a different situation throughout the state, and it leads to different structuring within the city.
Thank you, Mr. Chair. I don't want to belabor the point, but again, appreciate everyone's work and everyone's testimony. I just fundamentally think that if we want to have a system of care for Baltimore, which is a city which has a profound amount of trauma and mental illness, whether it's substance related or not, then we really need to build it and drive it and fund it. Whether that's through, in whatever those partnerships look like, we have got to put the commensurate amount of dollars into them if they are truly a priority. Otherwise, we're going to continue to, I think, have more of the same. But again, I want to thank you, Mr. Chair, and thank you to all the panelists. Appreciate it.
Thank you. Okay. So next up, we have, is there a representative here from Baltimore Crisis Response, Inc.? Okay. Hearing none. I do know we have Tisha Edwards on the line from the Mayor's Office of Family Success, but also representing MOHS as well. Ms. Edwards, are you still with us? I know we had some challenges in the beginning.
I'm here.
Okay. Brennan.
Did you want me to go on and get started, Councilman?
Yep, you can jump right in. Thank you.
I feel like I'm the person keeping everybody from dinner, their family. So I will be brief. I want to thank you, Councilman Burnett, Councilman Cohen, and other council members that are participating in today's hearing. I also want to just acknowledge all of the other panelists who have been a part of today's conversation. I think it was a much needed conversation. and starting this with comments from those with lived experience and interactions with both our law enforcement and our behavioral health system, I think really set the tone of this hearing and really puts a lot of things in perspective. So I just want to thank you, Councilman Cohen, for kind of organizing this convening and getting the right people in the conversation. I am glad to be a part of this vital and urgent conversation. The topic of mental health is core to the work we are doing across the Mayor's Office of Children and Family Success to lift up and support Baltimore's children and youth and to make families whole. Every day in our work, we see the impact of systemic poverty, structural racism, trauma, and other factors that are compounded and in many cases multi-generational. Sadly, in Baltimore, 42% of children experience 3 or more traumatic events before reaching adulthood. Councilman Cohen, please know you can count on the Mayor's Office of Children and Family Success as a committed partner in putting a spotlight on mental health, including efforts to remove stigma, improve practice and increase equity, and to ensure access to culturally competent resources to address mental health in our community. According to the Black Mental Health Alliance, in 2018, the rate of suicides for Black children between the ages of 5 and 12 has exceeded that of white children. And more than a third of elementary school age suicides involved Black children. And in research studies, Black people have indicated that mild depression or anxiety would be viewed as crazy in their social circles. Many of those interviewed also believe that discussions about mental illness would not be appropriate even with your family. Within the Black community, not only do we struggle to fight against community stigma, but there is also the issue of the criminalization of mental health challenges, which this panel has explored in detail today. So thank you for that. Despite this unfortunate reality, I am hopeful. The national dialogue is shifting, and locally, our leaders, including Councilman Cohen, has forged deep partnerships in the community with the Healing City Steering Committee. They are leading the way in developing a very localized approach that seeks to meet the specific needs of our community. You know, in Baltimore, we have many community-based assets to draw upon. Heart Smiles was founded in 2015 by West Baltimore native Joni Holyfield with programming focused on leadership, entrepreneurship, and giving back. Heart Smiles is all about uplifting young people in our most underserved communities and providing the supports they need. During the pandemic, Heart Smiles has raised the bar. Every day, Joni and her team of young leaders host virtual YouTube conversations to spur inspiration, learning, and discussion around mental health and wellness. The Black Mental Health Alliance is an essential community resource that can bridge the gap in communities of color. Specifically, the Alliance has been helping to lead the Resiliency in Communities After Stress and Trauma initiative called RECAST in West Baltimore to reduce the impact of trauma and build resilience in communities where civil unrest occurred in 2015. Baltimore City Public Schools is focused on student wholeness and knowing and supporting students' unique experiences, talents, challenges, and social and emotional physical lives. City Schools has assigned a social worker to every school. It's so encouraging to know that every child in our school system has access to a licensed social worker. School-based social workers can not only provide direct services to students, but they can reach into families to help identify gaps and needs and go beyond the school. Finally, Baltimore is rich in its mentoring resources, and we cannot underestimate the value of this particularly critical entry point for supporting young people struggling with mental health. Mentoring can take many forms and is really about creating meaningful relationships that inspire trust, caring, and love. Lastly, Councilman Cohen and I are co-chairing the city's trauma-informed task force. And I'm really looking forward to the work that we will do within this task force. Our office also staffs the Children's Cabinet that is focused on the city's work on behalf of children and youth in 7 key areas: literacy, early childhood, food security, youth homelessness, trauma-informed care, youth diversion, and removing barriers to success for boys and young men of color. All of these have enormous mental health implications and can potentially negatively impact our young people. Meeting our children, families, and communities' mental health needs will require commitment and coordination across agencies and sectors. And I am looking forward to partnering with all of you here today to make that a reality for Baltimore. Thank you.
Thank you. Are there any questions for Tisha Edwards? Councilmember Cohen?
Thank you, Mr. Chair, and thank you, Director Edwards. Appreciate how your office leverages partnerships as a way to advance the work. And, whether it's Black Mental Health Alliance or Joni Heart Smiles or any of the folks that you lifted up, I think identifying those organizations and entities that are trusted, that have deep roots, that are embedded in community is just a critical part of how we move any sort of strategy forward, given, I think, what you lifted up around stigma and just some of the challenges and barriers. And as we've heard throughout this hearing, just access, the costs of getting care. I do also think, frankly, that your office, as I think with our health department, should be better funded by city government so that you all could carry some more of that work. But that is a discussion for another day. Just briefly, if you could, I know that as part of the Children's Cabinet, trauma is one of your focus areas. Just briefly, if you could describe sort of where that work is headed and sort of what you've seen and where you think it needs to go, that would be appreciated.
So thank you, Councilman Cohen. I think, we are really trying to think through how to have a preventive approach towards addressing trauma, if you will. And really our goal and what our committee and work group is really focused on, kind of our charge is healing and resiliency. And when you look at all of the adverse experiences that unfortunately many children in our city have faced, the question is, how do we meet young people where they are? How do we build them up? And some of the cases that you all talked about today are specifically very sensitive mental health issues, but there's kind of a continuation of care that young people need. And we think that if we can get involved in young people's lives very early, provide early intervention, provide prevention resources and support like mentoring, so that young people don't feel isolated and so that they can get encouragement and support and that they can have someone to talk to, like making sure that we normalize some of the feelings that we all experience, right? Depression and isolation and anxiety. We've all had that at some point in our life, and helping to make sure young people understand that doesn't mean that there's something wrong with them. That doesn't mean that that they aren't normal, because it is normal. Some people have greater crises and greater needs than others, but the work group is trying to figure out, again, how to meet young people where they are and to have a very preventive and normalized approach, and also a culturally responsive approach. Young people like to talk about these things with their peers. They're not always going to go to an adult to seek help. Sometimes the first person they'll go to is a peer. And so how do we create the kind of education and awareness so that they can be resources to each other, reinforce where to go when you need help that your best friend or your girlfriend isn't equipped to give you. And so the work group is active. We're creating an action plan that will go out for public comment within the next couple of weeks so that we can hear from the public around some ideas that they have around meeting these specific goals. But I will say that it's a very diverse group of individuals who are on the work group, a very committed and knowledgeable and competent group of stakeholders who are really thinking about this from the children's point of view and really reaching into the youth community to be able to provide the kind of support that they would respond best to.
Thank you.
Thank you, Ms. Edwards, as well, for all that you and your team do. Okay, so I'm going to just ask, there were invites extended to the fire department and to the state's attorney's office. Are there representatives signed on from either of those offices? Okay. Hearing none. So Councilmember Cohen, I would say if you want to reach out to them for a statement, we can get it out to the committee for review. Okay, so we are now going to go to public testimony. Give me 1 second on pulling up the instructions. Well, I think I got it down by now. Save us some time. All right, so for people who are logged on to the WebEx, there at the bottom of your screen, there should be a button, or the top actually, that says participants, or drop down that says participants. When you click on that, there's a little hand at the bottom right hand corner that allows you to use the raise hand function, which will let us know that you want to speak. So if anyone that's signed on to the web-based part of this hearing, please raise your hand. All right, we got one. Quick, there we go. Rachel Sage.
Hey there.
Oh,
awesome. I think my video is not working, so I'll just do the best that I can. Thanks for the opportunity to be here, to Councilman Cohen's office for inviting me in on this call today. So my name is Rachel Sage. I'm a licensed social worker in Baltimore City. There's been a lot of talk about social workers in this conversation without very many social workers present. I only found out about this meeting today, and I hope that I have what I have to contribute is applicable. So I've worked in various outpatient mental health clinics known as OMHCs, shelters, and I currently work as a trauma therapist at a private practice in Baltimore. I have experience working with a wide range of mental health diagnoses and primarily work with people who've endured severe trauma. I'm here out of concern for access to adequate treatment for vulnerable populations and how OMHCs and the places that hospitals often discharge people to for further treatment can perpetuate trauma. OMHCs are often the answer for emergency services and have been provided as an answer during this hearing when referring to 30 and 60-day programs. I've witnessed OMHCs while working for them or just hearing client stories hold housing over clients' heads, trying to get social workers to see a maximum amount of clients as possible with low pay and little benefits, leading to high turnover of staff, lack of attention to detail by mental health clinicians, high stress, and increased negative effects of secondary trauma on social workers, as well as general difficulty with clients feeling that they can't build trust when seeking treatment due to high turnover and some of the other issues that I've mentioned. Treatment that vulnerable populations often receive is subpar and can continue to perpetuate trauma and exertion of power over vulnerable populations. Many of the people who own and operate OMHCs do not have backgrounds in mental health, and it's clear that they are attempting to take advantage of medical assistance in order to turn a profit at their clinics. Housing is often dangerous, and clients are often threatened with losing their housing if they do not attend treatment groups or sessions, which are often such a high quantity that it keeps clients in poverty, finding getting a job or getting back to work near impossible, and often leading to homelessness after completion of treatment. This can easily reinitiate the cycle of substance abuse or cause a lapse in mental health symptomology. I've noticed problematic dual relationships of hiring recently graduated clients to work as peers at the same agency where they receive treatment from, which can be problematic for numerous reasons, namely power of the employer over the employee, where the employer has significant personal and confidential information that is protected by HIPAA because the client used to seek treatment there. This is very, very common, especially in OMHCs that specialize in working with folks who have substance use disorders. This has only been my personal experience, but I can assure you that I'm not the only social worker to have these concerns. More oversight and accountability must take place regarding OMHCs in Baltimore if they are to continue to be the longer-term solution after clients are discharged from the ED. I'd also like to put on a personal hat and share a personal experience that I had in the past. I wasn't able to speak earlier when we were talking about guns and EPs. So in 2015, before I was a social worker, my partner at the time was threatening to murder people on our block and was hiding legally obtained firearms and ammunition in our home, and I was not aware of this. When I became aware of this information, I went to file an EP and was able to get directions on how to do this from BCRI. When I went to get the EP, I was informed later by police, and I happened to work for City Council District 2 at the time, and so I had a great relationship with our officers over there due to that job. And I was later informed by them, due to that personal connection, that I also needed a protective order in order to have the firearms removed from my home, and that the EP would not accomplish this. People who are hospitalized cannot be served with paperwork. So I'd suggest that people filing for an EP on behalf of a friend or family member to answer if there are firearms in a person's possession so that they can be directed to simultaneously file for a PO. Now, as a social worker, I've participated in numerous EPs where I was concerned for a client's safety. When police arrive, it often exacerbates the situation. Clients often become afraid, and it's a mental health issue that has kind of been turned into a crime from the client's perspective. If a licensed professional is calling 911 for an EP where the person is not wielding a weapon or behaving violently, I hope that we can have ambulatory or other emergency services to address these types of calls. If we are to decrease police response to mental health crises, I hope that the following issues can be considered. Self-defense training for social workers who are entering into potentially risky situations in response to a crisis. Minimum social worker salary and benefits for crisis intervention work. This work is highly taxing. Maximum allowable active caseloads to prevent human error, effects of secondary trauma, and staff turnover. Please see the Hernandez case for social workers who have been, penalized for an oversight due to very high caseloads. I'm not sure that I've obviously not had time to consider all of the things, but wanted to offer some of those that came to mind as I'm hearing everybody speak at this meeting. And thank you for allowing me to be present and for hearing my perspective. And I hope to continue to work with you all.
Thank you. Thank you for calling in. Thank you for sharing that. Okay, I don't see any other hands raised. It does sound like someone may be unmuted. Before I read, I think it's Martin Barton. There we go. Got it. All right. Thank you. I try not to put people on blast. Give him a second. All right. There are also people who have called in.
Excuse me, Mr. Chair. I think they all left.
Oh, okay. Well, hopefully we did get a lot of written testimony, so hopefully the folks that called also were some of the same people who provided written testimony. Okay. with that, we are going to, we don't have enough to vote this out on here. So what we'll do is, for now, we will reconvene this at a later date, and then vote out the resolution. If you're okay with that, Councilmember Cohen. Yeah, because a few members I'm looking in the chat, there were a few members who had to jump off for other reasons. So we'll vote this out. I do want to thank all of you for sharing all of your expertise, feedback, policy ideas, and stories and experiences, lived experiences today. This is an extremely pressing issue at a very needed time. So I want to thank Councilmember Cohen for introducing this resolution and leading this conversation, because as much as a lot of the narrative is around alternatives to policing, we do need solutions on what that actually looks like in reality. And this is a huge piece of that puzzle. So I look forward to continuing this conversation. And as policy changes arise and funding priorities change to back exactly what you all are describing, I think we'll be in a better space. Enjoy the rest of your evenings. If we were in City Hall, I'd say look under your chairs, make sure you didn't leave anything behind, but we are virtual. So thank you for staring at these computers for this long, and have a good evening. Bye, y'all.
Thank you, Mr. Chair.